welcome from a beautiful day in Sydney to our fourth advanced sinus surgery cadaveric demonstration. And fantastic news for this meeting. We've actually gone over the 1,000 registrants, which is a fantastic achievement. So welcome to everyone from, I know, all around the world. I know it's not just East, Southeast Asia, the registrants. So hopefully we'll have a fantastic morning and afternoon for you. Now, we do have the chat option available via Zoom, so please feel free to ask questions to Richard or myself through the chat function. We'll do our best to answer them. If we can't get to all of them online today, we will do our best to then respond via email over the next few days. So I'd just like to start by running a few slides to introduce APOST, which is the Asia Pacific Otolaryngological Surgical Training Group. So we're on the PowerPoint. So APOST is almost 10 years old now. When Michael Tong approached me and Richard and several other people with the idea of setting up a not-for-profit organization to try and train the up-and-coming surgeons from the Asia-Pacific region. And in particular, in addition to promoting training and education, we actually wanted to make ENT training accessible to those who were previously unable to access it due to financial reasons, in particular from the more financially challenged countries of the Asia-Pacific region. And over the last 9 years, I think we've been extremely successful in doing that, in what is a very challenging environment, raising funds. And we've worked with many of the societies and associations across the Southeast Asia region and made many friends along the way. So in addition to dissections like we're doing today, we have lecture courses and hands-on cadaveric dissection courses. In particular, we've got one coming up on sinus surgery in Bangkok in December. So for those of you that might be interested in applying for that, I would encourage you to submit your resumes online. We're always oversubscribed, but so please put as much in your resume to allow us to make informed decisions about who gets on. We've got some online and trained platforms and e-learning modules. A lot of our courses, the PowerPoint slides are online for you to access. So please go onto the APOST website and register, and also follow us on our Facebook forum, please. So the board members come from a variety of different countries. Michael needs to take the credit for starting it all, and Jason now, who's taken over the chair in Hong Kong, has taken up the mantle. And there's myself and Richard, who had been there from the start. We've got Taro from Japan, Prepper from Malaysia, Journaling from Singapore, and Corncat from Thailand. And in addition, we've got many individuals who commit their time voluntarily to help us on the courses. So we've got 2 narrowband imaging laryngeal courses coming up, one in June and one in August. And we mentioned the sinus course in Bangkok in December. So please check those dates on the APOST website and keep in touch. So just to introduce today, we have got many things to get through. We've actually got 2 heads, so we're going to try and cover everything without destroying the flaps on one side. So we're going to start with some anatomy and septal turbinate surgery, run through a standard sinus procedure, and then look at more advanced techniques such as the Carolyn's window, approaches in the frontal recess, approaches to the maxilla, the pre-lacrimal, medial maxillectomy, and of course do a draft 3. We're also going to do a DCR and a videoneurectomy, as well as the sphenopalatine artery. And then if we've got time, we'll move on to infratemporal fossa. But the main focus of today is to do the sort of sinus surgery which you will be expected to be doing in your routine clinical practice as either an advanced trainee or as a junior consultant. And the aim is to introduce you to some new concepts, many of which we think are well established and routine, but we're also aware that around the world some of these concepts and approaches may actually be new to you. And so if you can put some questions to us about why we approach the sinuses this way, and there's always logic. Richard's a very advanced thinker and always has logic and evidence behind the approaches that he runs through. And we're planning to finish at 3. If we don't finish before, we may actually finish a little bit early. Richard needs no introduction whatsoever. Many of you will have met him either online or in person at meetings around the world. He did fellowships in the States and also in London, where he trained with Valerie Lund, but also with Rod Schlosser and other mentors in the States. And he came back and set up the rhinology and skull base program at the University of New South Wales. He's extensively well published with a very high H factor, and has got dual professorial appointments. And I think most of you that know Richard know that he's very altruistic with his time and efforts, and spends a lot of time teaching junior surgeons, and is someone who, if you ever do meet at a meeting, please introduce yourself, because he's always happy to meet new faces. I don't want to say much about myself. I'm moderating today. I'm the number 2. I'm based in Adelaide and sort of have a sort of a hybrid background, having been trained in the UK, doing a fellowship in Adelaide, and then obviously being involved in APOST over the last 9 years. So sponsors, we couldn't do this without our sponsors, and in particular we need to extend our gratitude to Medtronic and Storts for funding the costs of today's demonstration. The IT support is always superb, and we'd like to thank the IT team in advance, and we'll get a chance to thank them again later, provided they don't crash the system on the way, which I'm sure will not happen. So thank you for bearing with me for that introduction, and we'll now go over live to Richard's camera, and we'll start with a bit of basic anatomy prior to doing the septoplasty. So good morning, Richard.
Good morning. Thanks, Simon. Can everyone hear me okay? Mandy, give us the feedback.
Mandy
Make
can
sure
give us
you're good. And obviously I'll get started. We good? We're good on my feedback? Okay. Just someone or Mandy, just let us know. So let's get started. I just thought we'd just go through a very basic FESS case and some anatomy. I think it probably is just worth also mentioning, Simon, we should sort of thank the sponsors of the APOST. You know, Olympus have been there from the very beginning. We've very kindly got support from Carl Storts and Medtronic, especially for this course. Smith and Nephew have been involved over the years, and of course there have been others, and please add if I've messed someone off. So here we go. We're going to look at a FESS course, and we've got 2 heads. I just wanted to show this head first of all, because it does have a little bit of a septal deviation. And even on this side, which is the away from the set, it's got a very strong swell body. And it really is going to inhibit access into the middle meatal area. And so I do think when you do sinus surgery, it's not whether or not I can work past this area and do my surgery. The question is, can I even look after my patient afterwards with a septal deviation? Because I think in real life, post-surgery, this would be very hard to work around, Simon. You know, it's not just whether I can get the surgery done under an anesthetic. I'm often thinking, is it possible that can I even care for my patient, examine the sinus cavity? What if I need to divide an adhesion or something else? So let's have a look here. That's your septal swell body. This is the inferior turbinate, middle turbinate. We have middle meatus here. And of course, in the middle meatus, we have the free edge of the uncinate here. That's the bulla. This is the posterior fontanelle while it's soft. The anterior fontanelle is in front of the uncinate. The uncinate's in here, anterior fontanelle's here. We've got the middle turbinate root here. And then when we look up, we should be able to see that's the superior turb there. It's a little bit pushed over, and that's the superior meatus. So that little cleft there is the superior meatus, superior turbinate, and an artificially nice view of the sphenoethmoidal recess and the ostium here for this patient. And of course, just like the maxillary sinus, the sphenoid has an ostium and a fontanelle, so it's soft there, and the hard bones down here. Obviously, this is eustachian tube back here, the lateral recess, and then when it comes into the nose, the nasolacrimal opening is often just a little tiny slit here, and we might have a look at one of the other heads to see if it's a bit more obvious. But often it's just a little slit in the wall, and I think that's probably going to be it there. It's not a hole or an opening per se. Now, one of the things we're going to do here is we're going to show very quickly a septoplasty, or how at least I do it, on getting in there. So I'm going to get Ling to hold our scope, and I'm going to stay where you are. So I'm going to wipe the scope here, and I'm just going to show, just in general, you can pop that down, I can grab all that. So normally with a Killian speculum, one thing we don't have today, I'll stretch the opening of the caudal edge of the septum here, and I'll inject my local. Now when I do that, I don't let go of the tamponade. So the tamponade stays very, very still, and then what I'll do is I'll cut down onto the cartilage. And stay where you are. And as you cut down, even though I can't really even see it with the colouring and everything, I cut down onto the cartilage. Once I've got the cartilage, I'll then scrape very gently. And it's quite good. You can sort of see it on the view still. I'll scrape it to the point. It's just beginning to come up now, where we've got a little bit of cartilage dust coming up. And we call this the cartilage dust sign. Can you see there we're getting a tiny bit of dust? I think we're almost there. Stay where you are.
So you notice Richard using the side and the back of the knife there as well?
Exactly.
Which means you're not going to go through the cartilage.
So yes, you don't go through the cartilage, but you have to get underneath the periosteum. So once you get a bit of cartilage dust, you should be able then just to slide your instrument in. And if you're not sure, stop, go back, re-scrape the matrix. Because by definition, if you're getting the matrix off, and I'm not quite getting it there. There you go, it's starting to come up a little
Those anterior few millimeters can be quite challenging. It varies from patient to patient.
And by just getting that little bit of dust means that I'm through the perichondrium. So then I'm going to take this, thank you, and then we'll slide in. So you can see now, you can double check when you're in. And you shouldn't see those fibers there? You shouldn't see any fibers. So actually, I'm not quite there, Simon. So I think we need to see almost. And you can see I'm heading up away from the area to make sure I'm in the right area. And then once I'm happy, I've gotten through. So now you can see it's separating and there's no strandy fibers holding us through. This now, you know you're in the right plane. Now, the first thing you should do when you're doing this is go all the way to the back, and for orientation purposes, go and find the sphenoid rostrum. The sphenoid rostrum will immediately tell you where you are from a height perspective. Don't try to make it all too broad initially, especially if you haven't found the sphenoid rostrum. Because you can see here, there's my rostrum coming up, I think. There it is there. And once I see that, that's the sphenoid rostrum, I know that then up here is going to be our olfactory and higher onto the perpendicular plate. And the lining here is often very thin. Can you see how Simon, now it's very thin. And it's not uncommon just to have mucosa on mucosa as you go through the olfactory. You can see how thin it is here. But as long as you find the sphenoid rostrum. Now the other thing about finding the sphenoid rostrum, it gets you onto the bone, and then you can follow the bone down here. Even though this bone is very thin, often it isn't thin down here. It's very thick for a lot of people. You can then follow that bone, and then once you follow the bone, you want to follow it onto the floor. Can you see that? So once you've got the floor, then you know that that's your inferior tunnel, as I guess traditionally it was taught. You want to come forward then on the inferior tunnel all the way forward, and then you'll see the tissues wanting to pull in here. And as they pull in, you know that they're going to show up. Now, if you said to me about dissection technique, it looks like everything's just splitting magically for me. It's not actually easy to do. I've got very, very strong pressure where my instrument isn't leaving the bone. It's constantly on the bone. So it doesn't matter if I want more access here, I just stay on the bone and the soft tissue spread. What I'm not doing is pushing the soft tissues. It's just following the bone. And then as we come forward, you can really see it now here, Simon, that incisive canal and the terminal branches of the greater palatine coming up from the palate. And then you can come all the way forward, and then we've got obviously a little tiny tear just there. But we've got this nice, now all the inferior tunnel open and all above here. Now, I just wanted to show this septal swell body because if you have a look here, it really shows you how awkward it is to get to the middle meatus. So for many of these patients, do we have a pair of scissors? Like the Mets.
The other advantage of having that wide tunnel right from the start is it then distributes the force through the whole of the flap.
Yes.
It's likely to tear it.
Exactly. I think when you get a tear, you want to go and mobilize the flap everywhere other than where the tear was. So you sort of mobilize it and make it as loose as possible. That's a great point, Simon. So I'm gonna come down here. You don't have to mobilize absolutely everything on the other side. I can feel myself just poke through that crest. But I'm going to take this off here. So give me the iris initially, or what have we got? We've got Metz. Let's go Blakesley next after this. So I like just to release it here. And where we are now is I'm just going to take the swell body out. Not take everything out. Take the swell body out just to show you how important it is to take the swell body out. So we're going to take this out. Often I would say it doesn't come out as one piece like that. It comes out as the cartilage. The cartilage first and then the bone second. Now, when you get this out, you may think you're done, but that's still not right in my opinion. This will still be in the way of a FESS. So let's have a look.
And it'll tent the flap.
It'll tent the flap exactly. And you can see it just there, right? So actually, see this exactly as Simon suggested, it's going to tent my flap. So let's come back in. Now, if you said to me, remind me where we are here, we're underneath the nasal bone. So you can see the bone there and the cartilage here. You should feel very comfortable releasing the cartilage from the bone at this level. This is nowhere near the support mechanisms to the nose. Let's go to scissors again. I don't like to twist all of this, but I certainly like, because I think if you twist it, sometimes if you haven't freed up the mucosa, you end up tearing the mucosa as people pull things out. There you go. And just that one maneuver, I think Simon's going to give us a really nice view. Look at that.
Yep.
And you can see it, that last little bit was really key for getting that right. Now I'll just wipe my camera here.
And people are sometimes scared of going high and taking that away because they're petrified they might get a CSF leak. But you saw how Richard tried to minimize the twisting. You know, you're not going to get a CSF leak.
And likewise, the olfactory mucosa starts a fair way back from all of that. So you don't have to worry about, you're not going to tear the olfactory mucosa. But this is really important, Simon. I think, if you said to me, where were we when we did that? This is a question I often get asked. So there's still a little bit of the bone just there. So I'm going to put that here. I'm going to measure my cotyl. And if I look on the outside, look where I am. I'm right underneath the nasal bones at that orientation.
Lots of support. You're not going to get.
You're nowhere near the what's it called? The keystone.
Keystone. Yep.
Yeah, the keystone area. I've even forgotten what that's all called. Because I do a lot of rhinoplasty work and nasal reconstruction work, and I just think that's really common. People who don't do a lot of reconstruction, they over worry about areas that aren't important for support, and it then limits their access. So I even took a little bit more off. Now, before I do a FESS, I really want to be able to see directly into the olfactory cleft like that. That's critical. And then a really common maneuver, thanks to Peter Wang and my colleagues in San Francisco, is the lateral lamella relaxing incision, where you just take a the middle turbinate where it converts from sagittal to coronal and just make little fractures. And look at that. And now it sits in a good position for a sinus surgeon to do his work. Now, on that note, I'm going to stop here, and I'm going to get the other head out. And maybe, Simon, while I do that, you just very quickly go through the scan and just show people loosely the head we're about to dissect on.
Okay, so this is actually shut down. Rich, do I need your... Rich is just going to log into the scans of this cadaver. So, are we on? We're good? Okay, so I'm going to start at the front and go back. So, as you can see, this head, you can see the septal deviation there, which has now been fixed, and we're coming into the frontal sinus there. Now, you might think that that's an intersinus septal cell occurring on the frontal, but in fact, that opens into the right frontal further back. And you can see there's quite a thick beak here anteriorly across the frontal sinus. And where that line of bone is continuous, you're obviously in the frontal sinus and nowhere near the frontal recess. So let's see if I can do this and move further back. Now, as we move into the frontal recess, we lose that continuity of that line of bone across between the orbits, and you can see the natural drainage pathway here on the left. And you can see we've got cells lying lateral and medial. And Richard will explain how he approaches a dissection in the frontal recess as we go through it. But essentially, you need to remove cells that are obstructing the drainage pathway, both anterior, lateral, medial, and posterior. And we've got very large agonese cells here on both sides. And as we go further back through the frontal, you can see we're into the maxillary sinus here with the osteomedial complex. You can see the infraorbital nerves there, which are very obvious, and we should be able to point those out when we're in the maxilla.
Do you want to show where the anterior artery is, sitting on the skull base?
The anterior artery, let's go, there it is there. Okay, so these, you can see and identify the anterior artery by this sort of little protrusion here, widely known as Kennedy's nipple in the industry. So you can see it tenting out, and of course it's completely in the skull base on the left, slightly inferior laterally, but as it moves further medially on the right, it then goes into the skull base. So it's going to be pretty well protected. It's not sitting low on the mesentery, and as we go further back, we obviously then want to identify what's happening around the sphenoid, the other danger area for sinus surgery, and as we come back into the sphenoids, we want to identify what's happening with the carotids, identify what's happening with the optic nerve, check there's not dehiscence. We can see here that dehiscence, possibly a partial dehiscence on the left carotid, which we might be able to see a bit more obviously as we go further back.
I mean, for me, Simon, I think one can really assess the scan as much as you want, but there's really only one absolutely critical factor that every surgeon should look at, and the question is there an anatomical structure sitting within your surgical field that couldn't be predicted? And there's really only three, right? The anterior artery, the orbital tissue sitting inside your ethmoid, and the brain hanging in a weird position.
Yep.
Everything else, in my opinion, you can judge at the time of surgery.
And it's amazing how often the radiologists miss orbital contents protruding into the ethmoid from a previous injury. And unfortunately, the Australian population are very fond of getting into altercations with bouncers and things like that, and get punched on the eye. And it's probably more frequent than we would realise.
Okay, so let's go to the endoscopic view. Tell us when you're back on. Okay, so here we are, here on the left-hand side. Now, this is the other head, right? So we haven't done a septoplasty here on this one. Now, so we'll do this lateral lamellar relaxing incision. So there's uncinate, there's bulla. You want to come in here. Now, I'm not pushing the middle turbinate. What I'm doing here is fracturing the sagittal to medial transition all the way down, and not just low. You've got to come up high through this bit here. This is what helps you release. You don't have to go through the whole thing, but you've got to go through, and I try to almost say keep the mucosa intact on the other side, and then that'll make it sit in a nice position. The backbiter, thanks, Ling. Now with a backbiter, we'll make a cut through the uncinate. Now people often say, what height? Really as low as you can go, but really you should be at the junction of the bottom fifth and upper 4/5 of the middle turbinate. You can see it there. We'll bite, and we'll use a ball probe here in a moment to dissect this. And we want to come all the way through to the fontanelle. So here we go. Now, with a ball probe now, we'll come in here, and you want to find the natural ostium if you can. Don't go here looking for it. Come all the way forward if you can. Now, you want to make sure we've come through the mucosa, which is just there. But where you want to enter is not there. It's way forward here. Because if you enter here, you can almost see it on the photo here. Like even with a 0 degree on this person, there's their natural os there. Can you see that? So if you put your curette here and go looking for it, all you're going to do is strip the mucosa. So you want to come as far forward as possible, and then you want to stretch, and not down, but up. So you don't strip the roof, and then we'll get a straight through cut, the small one, here. So you want to stretch it enough so that you can get a straight through cut in. And the way that you want to do a through cut is you want to do what we call the lazy L. So you want to bite, 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 back, and then we come down. And you want to go high, but you maybe don't want to go absolutely all the way back. It's nice to leave yourself a little strut here, otherwise you get a little bit into the bones. And that's where you want to go. You want to go all the way down through the fontanelle, down to close to the root of the inferior turbinate. Can I have the back biter now? So that's my lazy L. Give me the ball probe. I just want to describe the lazy L, we call it. So it's an L sitting on its side. It's one of the best demonstrations of the L, Simon, I think there. And then with a back biter, we'll then take off that inferior uncinate. Now, I see still around the traps people who do uncinectomy where they try to take the top uncinate first. Look, I know that was traditionally how it was taught, but I really think if you want to avoid bleeding onto your field, you don't do that first. Do the bottom bit first. And so if you do the bottom bit, take all of that, come along, and as we came along, I came back up to the ostium. You just keep it nice and clean. Then do the upper uncinate. Now, if you go through here, you're likely to get in between the layers of the uncinate. So I do think it's sometimes if you want to pull the uncinate out into a favorable position, start where you're not going to accidentally get into the wrong plane, pull it out as best as you can, and then here, maybe with a small up through cut, we'll cut off the uncinate. Now I've just pulled it into a position that's favorable, and then I'm going to pull it. Now when I first get it, I often give a little tug rather than just simply biting it, because you want that fontanelle, and you can bite pretty comfortably till about here, and then you need a straight through cut to finish off the top edge. And then with this top edge, we'll cut this off, and then that's your uncinectomy. Now there's lots of different ways of doing that. We'll go a curette now.
But interestingly, not a sickle knife in sight, Richard.
Yeah, yes, exactly right. Yeah, I don't really do it with sickle knives. But I'm open to anything, though. So people put freers in and can mark it off. You can just go through the posterior fontanelle and then connect everything afterwards. You shouldn't get too bogged down in, I've got to do it this way. What you'd want to see, though, is you want to see the roof of the maxillary sinus or the floor of the orbit. Now, once you find the floor of the orbit or the roof of the sinus, you've got to see where that guy becomes a vertical wall. So that's what we're going to find now. I know people think you're doing a bullectomy, but it's not what I'm doing in my mind, up through cut. What I'm doing is I'm getting rid of partitions so that I can see the medial orbital wall. No.
And you've got to be able to see that natural maxillary sinus opening. It's amazing how often we see students who think they're there and think that the ball probe has fallen in when in fact they're just not anterior enough. Because if you don't get it right, you'll create a false drainage pathway through that posterior fontanelle.
Okay, here we go. So we've just taken the front face of the ball off. We're gonna do what's called the crunch and gobble technique, which is where we just make a bit of a mucosal soup out of everything. And what I'm doing here is I'm looking at the floor, and then I'll give me a kerosene, and then we'll use a shaver here in a second. We can clamp and swap over.
So there's a question coming, Richard, about the septoplasty, about any particular tips about dealing with that crooked anterior part of the septum, when you've got like a hockey stick anterior twisted septum.
Yeah, I think if you're trying to do it endonasally and you think the plate of caudal septum is actually still straight, then just making sure you completely detach it and release it from the spine and make sure it's not too long. So if it's too long in a vertical position, it'll never sit right. But I must say I've got an incredibly low threshold for doing external septoplasty. And that comes from my rhinoplasty background. So I am happy to fiddle with it if I really think it's straight to the actual caudal end. But very quickly, if it's not right, You'll need a stylet here because I think this has gotten blocked in a heartbeat. Okay, give me a curette. So all I was doing here, I made my mucosal soup and then tidied it up. All I was doing is I wanted to see where the floor became the medial orbital wall. Can you see that, Simon?
Yep.
Now, I know that that's there, and here's the floor. That has to be the medial orbit. And it doesn't matter, you know, if this was full of tumor and everything else. If I can see it turn, and with a straight through cut, sometimes I'll even really force it, Simon. I'll like come in here and I'll nibble to be 100% certain. Give me the curette again.
And it's a bit more difficult in the cadaver, but in live surgery, you know, pressing on the eye, you'll see that mass movement, which will also help.
I'm gonna show it here in a moment.
Yep.
Because if I really wanted to convince myself, and you know the patient wants you to be convinced, right? You know that you know where it is. There's the floor of the orbit. That has to be the medial orbital wall. And look, when you press on it, it's got that mass movement, Simon, that is very typical of the orbit. Can you see that?
Yep.
Don't you? We call that Cohen's sign. Shout out to Noam Cohen. You know, that mass movement there. Okay, so now let's go an up through cut.
And the important thing there is you can see that curve. You can see how the roof of the maxilla just curves around that corner. If you can't see that, then you're not quite onto the orbit yet.
Yeah, and a little bit. Give me the freer thing. Oh no, not the freer. The shaver. There's just a bit of loose mucosa, because if you were doing an OMC surgery, you know the surgery's over now. But I want to show you this. So give me a curette, thanks. If you're doing an OMC procedure, you want to make sure that you can at least see the cut edge of the uncinate nice and clear. There it is there. So you've got the cut edge of the uncinate, the cut edge of your agonasi, and the cut edge of your bulla nice and separated, and get rid of any bone flakes. Because if you're going to end an OMC procedure, say you were just dealing with a unilateral maxillary sinus disease, you don't want to create a secondary problem. And the way that you avoid secondary problems is just turn the...
By seeing those, make sure there's no iatrogenic adhesions.
Yep, just turn it. So there you go. So it's coming. So you want to make sure that you don't have the edge here. It's not folding over onto each other. You know, so you're not going to create an iatrogenic occlusion of your frontal recess. Now let's go on and do the rest of the sphenoid. So the reason finding the orbit's so important, because if we come across here, we know that there can't be any skull base at the level of the orbital floor. So we're going to make an opening through here. Now, don't make the opening way over here. Make it straight through the middle here, and then with a up through cut, we'll now divide the basal lamella. Now, for those of you who are looking and saying, I just want to follow my SL tract, you can't follow SL tract here. There is no connection with the anterior ethmoid and the posterior ethmoid. So we're going to make this big here, and we're at or about the level of the orbital floor here. So you want to make an opening. It's not about being entirely below the orbital floor. It's about making sure you're at or about the level of the orbital floor. Then with a straight through cut, we've taken the front wall off, just like we did to the bulla. We're now going to divide. You see this, guys? How this is, Simon? I call this the half Y over here. This is the half Y. So we're going to divide this. So we're going to divide this. This is sometimes referred to as Larry's plate. So Professor Larry Kalesh is a very well-known rhinologist in Sydney, and it's very important to get rid of this plate of bone that extends over the maxillary sinus. This bit of bone, if you don't remove it, you will not expose a huge amount of posterior ethmoid. And so getting this plate of bone that goes over the ethmoid, over the maxillary sinus, is so critical. That's one of my biggest things I see people not do. They leave behind a big retromax cell or a posterior ethmoid cell. And now with the shaver, we've got our crunch and gobble up again.
So there's a question from countries where the microdebrider, presumably for financial reasons, is not readily available. How, with the crunch and gobble technique, would you modify that?
Yeah,
and just pull it out
you have to spend a lot more time just biting it all, and then you just suction it away. So you can see there, I could have just bitten all that up and washed it out, and my sucker, I would have had like a 10 or 12 gauge sucker, Simon.
Yep.
And I would have done the same technique, but I would have to do a combination of irrigation and suction to get rid of my chunks.
And you can irrigate it all out. It just makes it a bit quicker.
It's just obviously so much quicker with the shaver. And the shaver does a nice job of just getting rid of the last little cut edges if you haven't quite taken the care to bite everything. Now, the next thing we're going to do is just widen our opening through the basal lamella. Curette, thanks.
You can see you're into the superior meatus then.
Exactly. So sometimes you can't see it like this, and if you can't, we do what's called the wiggle. You see how I'm wiggling it? So when I wiggle, the back bit doesn't move, but the front bit does. And where you see that junction point, you know that's the superior meatus. This one's plain as day, but the old, what we call the Charleston wiggle, shout out to Rod Schlosser, you give it a wiggle, you can't see it move back here, and you know that must be the point of the superior meatus. So give me a straight through cut. Now this is so important because I think there's many people, well now, your dissection is not up through here, guys, because when this is full of tumor and polyps, you don't know where the orbit is in the skull base yet and the lateral lamella. You know, we're going to do a full house FESS here. We're just going to go straight back and find the skull base and the orbital apex. Now, when you do it, I think when people see the orbital floor, Simon, they get very confident. They're just like, oh, I'm just going to whack this off. But actually, your job as a sinus surgeon should be to preserve as much of this as possible. So I want to show you how little I often will take. So I will come down here, and I will take just enough so I can see the beginning of the sphenoethmoidal recess just there. Can you see that? And
Richard's group did a really good anatomical study which showed the relationship between the orbital floor and the location of the sphenoid sinus.
So here we go now. So now we've got minimal dissection. Here's our sphenoethmoidal recess, and you can see me just dropping in there. Can you see that? Give me the shaver and I'll just get rid of those little chunks before I demonstrate that. Now, I do this all in a heartbeat in real life, right? And we'll do it very quickly on the other side later on this morning. But here you go, drop in there. You can actually see the ostium, but you don't need to see it. You just put the curette in. Look where I am relative to the orbital floor. I'm checking it. So I put the curette, and it doesn't matter where you go through the natural ostium. You can go through the fontanelle, but you can see my curette. So you go in, turn around, and then you stretch down. So I really got, and if you said you're not sure where you are, you can always go in, turn 180 degrees and pull back on yourself. You can see it, and then I push down. So when you push down now, we use a kerosene up, and we want to go and find what's called the corner pocket. So the corner pocket means that we're going to come in now through that opening, just like I stretched the maxillary sinus opening to get my straight through cuts in. I've stretched this so I can get this in here.
So a question about the descending palatine artery in Larry's plate. Do you ever...
they're not in the same location. So give the shaver. And then we'll get an up-through cut here in a moment.
Speaking of vessels, there is, of course, that septal branch.
Down here, way down there.
So you've got to be careful down there.
Yeah. I actually almost think that most of my sphenoidotomies pick up the beginning of the septal branch. So there's several of them, so you don't have to be too worried. You just got to be mindful, I think, Simon, that when you go down there, don't expect it to magically come good. And you can see here that we've got a bit of an anode cell here. And I tell you why I know it's an anode cell, because I can't see my corner pocket. My corner pocket's way up here. And we call the corner pocket, it's that superolateral junction of the sphenoid, or the skull base, and the orbit. There's my corner pocket, right here.
A lot of people get very anxious taking away that anterior sphenoid wall, and you really don't need to if you know where your anatomy is.
Good call. Yeah, 100%.
There's nothing dangerous there.
You've got to see your anatomy to be safe, actually. It's not seeing it is when people make errors of judgment, right? So there you go there. Give me the sucker, the plain sucker. Just release that for a second. Now, right now, I can't quite get my sucker in the retroclival recess. So give me a kerosene.
And as Richard mentioned earlier on, it's also you've got to think about post-operative maintenance as well. So with this wide anterior opening to the sphenoid, you're going to be able to see this in the rooms when you're seeing this patient post-operatively. And with a small sphenoid opening, that's just not going to be possible.
Yeah. And you've got to remember too that a lot of getting patients right it's not a ventilation or a blockage problem. A lot of the reasons why sinus cavities stop working is they've lost their mucus clearance, they get mucus plugging. And that's why irrigations are such a big part of getting people better, because they help to restore mucociliary clearance and recovery. So here we are here. I know where the roof of the sinus is, so I'm not worried about anything there. I've made this a bit lower, and as Simon said, I'll probably get into a little septal branch here, and you need to bipolar it. You know, someone said to me they'd done FESS without ever using bipolar, and I said, you know, oh my gosh, you know, you've got to have a bipolar handy, you know, when you do sinus surgery. And then so it does mean now with that little bit of extra opening, see how I can now place my sucker, a straight sucker, into the retroclival recess. And to me, that's a sinus cavity that's now accessible. You know, Simon, if it got a big crust or a mucus plug, post-operatively, I could manage it properly. So give me an up-through cut now.
Do you worry if you go into the contralateral sphenoid?
Oh, sometimes you will if it's a really funny opening. And I think if you do that, that's fine. You just end up taking down the intersinus partition as part of your sphenoid opening. And you're better to do that and make sure you've got an accessible ipsilateral side than have one that's not accessible. Now, you have all the anatomy you need. There's the orbital floor. See how that was always going to be a safe zone to get into the sphenoid. Even if there's a big osteoma, I could have just drilled and found the safe zone here. We know that that's the optic there, that's the carotid, the opticocarotid. But to me, what this is the back of the orbit, this is the skull base, that's the orbit over here, and of course, the other medial boundary is the middle and superior turbinate. So now we're going to do what we call running the ridges, right? So we're going to, first of all, cut through these partitions, and often I don't worry too much about it, I just will cut through a big chunk like this. Give me a kerosene up, and I do think it's really useful to do the old Jim Palmer anterior agonasectomy. So the front wall of the aga is going to come off here, because I can't really see the upper ethmoid. I mean, you can see how tight it is already, Simon. I can barely see anything. So I'll commonly just remove this so I can see a little bit higher. And even though I do a lot of sort of Carolyn's and, you know, extended frontal work, I still try to make my sphenoethmoidectomy as comprehensive as possible, so my frontal work is as easy as I can be. Now, it's just a big mess of cells, so I'm going to come back and do what's called running the ridge. So running the ridge is where we pick this first ridge. You want to see it come off the superior turbinate, over the top and down onto the orbit. I'm not a big fan of people who still teach things like, oh, don't press the shaver at the orbit and things like that. If you don't know where the orbit is, that's a good idea. But once you know where the orbit is, it's your job to make sure you get those partitions off. Don't leave the patient with retained cells because you're simply worried about the position of the shaver. You could find the orbit, be more confident you know where the orbit is than anything else. So we'll take that away. So let's come here. Here's the next ridge. Can you see as we come across? As we do this ridge, come across here. We want to come down the ridge. It's going over the top, down onto the orbit. Give me a straight through cut. It's a little bit more than I'm going to use with a shaver.
Think of it as a series of croquet hoops.
Yeah, exactly. So you cut all that. Give me an up through cut. And you can see I still do a fair bit of hand dissection. And of course, in a normal mucosa and a cadaver, and I've got the suction turned up, it's going to strip a little bit. But obviously in real life, we try not to let the stripping happen.
And with the 45-degree instrument, you saw in the posterior ethmoid, Richard was putting it behind the partition. You know, you can confirm the cells behind, but you really, you know where the skull base is. You know you're not in trouble.
So we found it back here, Simon.
Yep.
So that's found it. Then I know that skull base. That's probably posterior ethmoid artery. Here's our next ridge. And you see it's here. You've got to turn the shaver a little bit and get right up to the orbit. If you don't do it here, you're going to struggle later on. So I think it's really important. You've got to maximize your ridge every single step of the way.
And you see how smooth that orbit is?
Yeah, 100%. That's how people leave a big row of cells against the orbit, because they don't find it properly down here. And they leave this little ridge here, and that means the next ridge is even more so. And you can see we're stripping a little bit, but you know, in real life, you said to me, what would I do to stop stripping? I would just turn the suction down. A bit more hand instrument, turn the suction up. But anyway, here we go here now. But I can really confidently come right up there. Same story here. Come right up onto the orbit. And every ridge we want to see it. This is the next ridge here. Up it comes over the top. Here's my next ridge. Now, about here is where you might start, because we're getting behind the bullet, we might start to see the anterior ethmoidal artery. I think you can here in a moment.
People asking about prevention of synechia. I mean, a lot of it is good technique at this point.
Yeah.
You know, if you're not stripping the mucosa, you're running the ridges. And we can talk about post-operative, at the end of the procedure. What do you put in there? Do you put anything in? There's a lot of controversy about that.
Yeah, correct. And the best way of stopping a shaver strip is just turn the suction down. And most units have suction control. So here we are now. Give me an up-through cut. So you can actually see now, by removing this little window, Jim Palmer style, it's given us access to the skull base. We can see the anterior ethmoidal artery here. This is the back of the bulla here. So there's even still like a tiny bit more of a dissection that can happen here. But we're getting very close, Simon, I think, to what would be the limits of a dissection through my enlarged middle meatus. What do you think? Here, let's have a look here.
Andrew Lomas has asked a question about when the mucosa is essentially not attached to the bone and just strips away. How do you cope with that?
Yeah, I put a patty on it, go somewhere else, go to hand instruments. Yeah, exactly. Yeah, do all those little maneuvers here. So if this started to strip here, you get up through cut, and sit there, try to re-establish a bone mucosa plane when you do it. And you can see the mucosa coming away. See if you can re-establish a plane. And then I'm going to probably stop here in a moment, because the rest, you can see how I'm almost working my camera over the top of each other. And so we'll tidy up this. The best way, though, is just keep it all low. The other thing I say is that if your sinus mucosa is so fine and stripping, you have to ask, why are you there? Unless it's an approach to something. Yes. I would say, most of the time when the mucosa is thick and chunky and diseased, it doesn't strip very easily.
Yeah. And someone's asked about approaches. What do you do differently if you're doing a pituitary? Is your approach different?
No, very different, yeah. So this is we're demonstrating, first up, maybe we should have made that clear, when demonstrating the concept of creating a neosinus cavity. Curette, thanks. And you can see this little bit of mucosa ballooning in here. So in order to stop it from stripping, there you go. So there's a couple, and we'll tidy all that up at the end here. But this is the cavity you should have at the end of your dissection. You should have this little vertical strut here. So this is in creating a sphenoethmoidectomy, because being able to do a neosinus cavity where you've opened the maxilla, you've connected it to the ethmoid, where everything's been removed, and you can see here, I could be even more pedantic here, Simon. You could really trim this off even further. But you've got to do it. Otherwise, if you don't do it, you'll leave a cell behind against the orbit. You want to see the orbital wall from front all the way back to the optic. There should be nothing that you can't see. You can leave a tiny little ridge, but you should be able to see from one to the other, to the other, to the other. That orbital access.
And do you always use a curette, or
no, almost use these hand instruments. I'm just using a curette to demonstrate. I'd never use a curette in an operation to pluck things. Well, that's a great way of stripping. Yep. Yeah. It's a great way of stripping and creating it. You run the ridge. So you run the ridge, run the ridge, run the ridge, run the ridge, run the ridge. And then here I get a bit lost here because I can't see above it. And I know that the anterior ethmoidal artery is in there. And I can't see above now. So we have to get access above. So let's go now. Now we don't have a diathermy, but we have a sickle knife. And we'll mark out the flap that we use in Carolyn's windows. Now, the first thing we're going to do is we're going to drop a vertical down. And if you're going to drop a vertical down, it's not here. That's actually leaning towards us in three-dimensional space. The vertical has to be sort of almost looks like it's behind, the root of the middle turbinate. And that's my one trick, I would say. I do this with a diathermy, of course, but that would be my one trick, is that almost make it so that it looks like to you feel initially when you first do this that maybe you're behind the root of the middle turb, but you're not.
Use that little angled Colorado needle?
I use a needle point that I bend at the tip. Now, the next incision, I'm going to really force this for everyone here. It's not here like a DCR. It's actually over here. So if you're going to make a Carolyn's window and you do what's called the lateral wall flap, your incision has to be on the midline or even slightly more than that before you then come onto the lateral wall.
You've got to remember, you are taking that bone between the frontal sinus and the nasal cavity.
And sometimes it's narrow, Simon, so you need to expose the midline. So here we are. Here we're gonna get down through the bone, and then anteriorly there is really no reason not to come anything other than all the way forward to the piriform aperture, because if you make this flap big and broad, it actually heals much better. If you just create a little strip down here, you end up creating a situation, I think, where that flap is often much more edematous.
And you saw Richard palpate there, so he can identify where the piriform aperture is.
Yeah, we should point that out, shouldn't we? Yeah, exactly, yeah. That's me looking at to see where the upper lateral. And don't go right on it, right? Give yourself a break. Make yourself that incision, and we'll use a coddle here in a moment. We'll make that incision in a sensible position. Now, the reason for doing this flap, and shout out to Brad Woodworth, I've tried a lot of different ways of doing this, but Brad saw me dissect once many years ago and said, Richard, you're all doing it wrong. This is how you need to do it. And, he was absolutely right. And, I make my flap a lot bigger and broader than Brad originally described, but essentially the idea of bringing it down so you can now just essentially dissect anteriorly to posteriorly just makes so much sense. And it does. It holds very well. I really do think we have got to credit Brad Woodworth with promoting flaps in modern day sinus surgery. He's done.
I spoke to him about that at the Sydney ASONS meeting, and he said, "No, it wasn't me. I just borrowed it from others."
Oh yeah, there
he's
you
a very
go.
humble man.
I think he's being humble. Yeah. Okay. So here we go. Here, this is where I didn't quite get. Oh, there you go. It's finally come through. See, and you got this lovely now flap that sits down here, and you can really tuck it out of the way. It doesn't need to come out your nostril or anything fancy like that. And obviously, we'll put the drill on here, Ling, and we're going to drill this bone away here.
But it has to be low enough that it doesn't get in the way of your drill and your microdebrider.
Correct. Yeah.
And for those people who are new to the Carolyn's window concept, it's essentially an extended draft 2B, but you're coming anteriorly, and Richard will describe that.
Yeah. Or even I sort of think of it, Simon, as just being an extension of all the things that people have described. PJ used to describe the little auxiliary flap and nibbling the bone. I really think of it as Jim Palmer's version. Jim loves to really aggressively do the bone up here with a kerrison. And you know what? With people who have a very big agonasi, Jim can do with a kerrison what I do with a drill. But the nice thing about using a drill is it doesn't matter whether someone's anatomy is favorable or not. You can still get there all the time.
Yep.
So even if you don't have a big agonasi, you can now get a really nice opening.
Or you can start with the kerrison and finish with the drill.
Yeah, exactly.
The kerrison does save you time.
And you saw I did a bit of kerrison action to begin with.
Yep.
Now, the first thing you should do when you do this is you go laterally and find the periosteum. And that's a shout out to, PJ. PJ used to describe that in his, his original description of how to do a Lothrop, where he was coming from inside the frontal recess. And, he used to go out here and want to find the periosteum early. I think that's a really good thing to discuss because really gives you the ability. There it is there. Can you see that now?
Yep. And with a diamond, you won't go through the periosteum.
Correct. But you can really see the change in bone. See how it's flat there and we've got the marrow here? Now you can drill it even more if you really want to show it. But you don't need to expose the skin, right? See, I've got the skin a little bit exposed now. You'll get used to that, people who drill. So that's actually exposed skin, but you didn't need to take it that far. In real life, you can see it. But give me the curette now. So I want to show you now what we call Ritter's triangle. So Ritter's triangle is this block of bone that's bounded medially by the root of the middle turbinate. The apex is here, and then the other triangle is formed by having that skin exposed. So this triangle is the triangular bone in front of your frontal recess. Now, give me a coddle dissector. Someone said to me, what if my root of my middle turbinate is not there or it's very narrow? Well, you just go back to the traditional teachings in like outside in Lothrop, is go in here and find your first olfactory neuron. That may be an accessory.
And there it is there. There's a little vessel there as well.
Yeah, it's a little vessel, but that's the first there, right? You can actually see it going up in that little there. So you can find the first if you have to, if you're not sure. But if you're staying entirely lateral to the middle turbinate, then you don't have to worry about that. But really, once you've done that, you can have great confidence now on what you drill, right? Because we've found those anatomy. You can see how it's not sort of guessing or anything else. We're in that zone. And we'll see how tight it gets. Some people it stains very broad. Some people it gets a bit tight, and you might have to go closer and closer to the midline. As you said, we may even head across into that midline big. But you don't want to go into the recess. The whole point about doing this surgery is to stay outside the recess here. We want to stay always medial to the periosteum. And you can see I'm not trying to expose the skin the whole way up. you know, you just want to you want to keep the periosteum on your lateral boundary. You want to be very convinced you're there. You might want to make sure you've got something ready to poke out the drill. And this is the one problem here, and I'm just speaking to Ling about making something to unblock the drill. When you get to this point here, there is a sense that you are drilling with the pole of the burr. And it's not much drilling, but I think sometimes when you drill with a pole, it's not particularly efficient. You tend to block up the drill a little bit. And you know that that's not going to be, block it up. It's not the best way of using a drill. You should try always to use the equator or the side of the drill when you're doing surgery. But you can see how we've got Ritter's triangle up here, and it's getting smaller and smaller, and we're almost there, Simon. So a little bit more drilling.
So the size and angle of the burr, is this a 15 degree?
It's a 15 degree, so it's got a tiny bend in it, 4 millimeter, which I've really found you don't need to go any smaller than that. If you need a bit more space because it's tight, you do what I'm doing here. You just come across into the beak anteriorly.
You ever used the choanal atresia burr?
It's a choanal atresia.
It is the choanal atresia burr. Yep.
Yeah, it's the Medtronic one. It's attached to an M5 that we have here. Just poke that out for me. And then we can put the clamp back on the sucker, thanks.
And the other interesting thing you'll see throughout Richard's dissection today is it's all with a 0 degree scope.
Yeah, 100%. And this is the nice part about it. Someone else said to me about, you know, there's such a good view when you do Carolyn's. Well, one of the reasons is my camera is not in the frontal recess. So my camera stays outside of all the blood and everything else. You can see where I am, right? I'm not really in the frontal recess. So this is the nice part about it. You're doing your surgery from this perspective, right? So you're staying outside. And I would encourage you that those people who want to do this technique for the first time, always stay as anterior as you can.
Anterior is safe.
Yeah, and there's a little bit of periosteum to come up, so we know where we are there. Anterior is safe. And don't stick your drill into the frontal recess. The whole point of this is to have the confidence, remove all the bone as much as you can in here. And as you remove it, you'll start to see the mucosa of the frontal recess come up. And here it is here, Simon. Now, the problem here is that even though you can see it, I would discourage people from going into it.
Yep.
Don't go into it. Just because you see a bit of mucosa, there's a natural instinct for everyone to want to pop in. So if you see a bit of mucosa, hold off now.
Because if it's disease and polyp, it's going to bleed.
Yeah, bleeding and everything else. Yeah. Whereas when you're doing this in real life, it's like doing a canalplasty. The bone is really nice. It's often with the drill, the diamond drill. It's very good hemostasis. It's a nice little bowl that irrigates nicely for you. Now, and you want to get as far up as possible anteriorly. So if you see a little hole down there, if you sometimes enter this, you'll be staring at the back wall of the maxillary sinus right in front of you because you've come in at too shallow an angle. So really then work hard to remove the bone above that little area that you see. And what it'll mean is that when we enter the frontal sinus, we'll have a much better trajectory that'll take us directly up into the apex.
Yep.
And of course, once I'm in, then I can use the equator of my drill to do it.
And someone mentioned, obviously, you know, if you've still got that septal swell body, you're going to be scuffing the drill on that. It's going to lead to adhesions. It's going to bleed.
And you can see here, if I'm going to get into the sinus and break through, I'm going to do it where I'm anterior. And you'll see why in a moment. Because you need that anterior. You need that anterior axis to see what you're doing. And this is your thing about those frontal cells, Simon. You were pointing out before. So here we go now. So the nice part about doing this is that even though there's a bit of an intersinus partition coming across to this side, it doesn't make any difference to the Carolyn's window surgeon. You know, if you find an intersinus partition, you can just get rid of it. And I'm intentionally not opening it all up yet because I want to show you what you do in real life. You don't want to stick the drill in the frontal recess, right? What you want to do is thin it down till it's just blue lined, so you can get as thin as possible. And I would really encourage you to get it as thin as you possibly can, so you can almost see the mucosa before you try to do the rest with hand instruments. See how it's quite thick here? It's amazing how thick this is for some people, Simon.
Yeah, and we saw it on the scan, it was quite thick in this individual. And that's why you just will not get through that with a Kerrison.
Yeah, so it's too big for a hand instrument just yet. But you've got to have faith, right? Have confidence about where you are. The skull base is not coming up. You have to go through the frontal recess to get to the skull base and all the other cells. So have great confidence that you'll be fine. And then I think somewhere around here, we'll see if we can get the instruments through here. So let's put that down. Let's go to a shaver now. And this is one of the advantages of doing this dissection now. So we've left ourselves this area up the top here. Give me a Kerrison up. And I always think it's amazing, even in a cadaver, Simon, about how much upper ethmoid still exists, even though it looked like I'd done such a complete ethmoid before, don't you think?
And now you can see it and you can finesse it.
Yep, exactly. Now, you can come back into run our ridges. So that's where we ended it, right? Where we saw the anterior ethmoidal artery. So you can take them one at a time, you can take them all together, but it doesn't matter. We know that skull base is there, orbit is here, olfactory cleft is here. We're just going to take everything in between.
So someone asked about tips to identify the anterior ethmoidal.
Look at the scan.
Look at the scan and know your anatomy,
Yeah.
and you will find it.
Yeah. No, the reality is that 85% of the time, Simon, you just look at your scan, and then that's it. 85% of the time, you don't have to worry about it. The 15% of the time that you need to actually look for it because it's hanging low, well, when you get through the bulla, the back wall of the bulla is where it should be, you know? So that everyone's sort of familiar with that anatomy and landmark. Okay, so we've got the shaver on now. Okay, we're not quite all the way through, but you can see here, Simon, how I've been reasonably conservative. Do you want to release the suction so we got a bit more suction?
And you can see the exposure you've got here. You can see where all those cells in that frontal recess are going to be.
And look where my camera is too. I'm still sort of almost working outside of the recess. And see this really hard ridge here? Oh my gosh, imagine encountering that with an angled camera. It'd just be so hard. You'd have this sort of angled ridge that you'd have to get rid of. Give me a straight through cut. But I don't like it for here. Just with a straight instrument, let's get rid of it. And there's that sort of suprabular cell just there, Simon. And give me an up through cut. I'll get that little ridge going laterally. Cutting, creating a mucosal soup. And, you know, have to forgive me sometimes in a cadaver, it does strip because it's a cadaver. And we don't have suction control. There you go. But I really want to do it now. There's a couple things we haven't done. So give me a Kerrison, a baby Hoseman. So you can still see I'm still using a 0 degree. You can see how we've got a nice cavity that's forming now. I'll go the baby Hoseman again.
So it's really important to emphasize this is all 0 degree. You know, the number of times I see people reaching for a 30-degree scope early in a FESS.
Early, yeah.
You do not need it. And from a medical legal point of view, I'm sure Richard will back me up on this, a lot of the cases I've been involved in, the complications occur when people are using angled instruments and getting disorientated, where they're using the angled scopes.
Yeah, I mean, I'm not as good a surgeon, Simon, using angled scopes and angled instrumentation. Now, that's not to say that we've got some colleagues of ours have developed amazing skills working with angled instruments. So, you know that's great if you are. But,
it is.
But if you're learning, there's enough times we still have to pull out angled scopes. If you're learning, you're much better off doing something where you've got access. And you can see I can't really get in there because all this bone's still there. But I want to show you now what our opening is like. So I haven't even done anything more here. So give me a Blakesley.
The analogy is, you know, which I often use, is it's like driving a car in a foreign country where you're driving a car on the opposite side of the road. You can do it, but it's just, you know, you're far better driving the car, you know, on the same side that you're used to.
Yep. So here we are here. Try not to. So there's our cavity, right, from front to back. And you can still see, like, I was reasonably pedantic at trying to get most of my partitions. And you can still see how you've got little things poking through. I would really try in a real-life case to get all of that. And one of the tricks you can do is with your shaver, go to forward mode and turn the suction down. And you can just run along the ridges. So if you said to me, Richard, if I really want to smooth it down, my colleague Raywin Campbell in Sydney does a lot of this, where, you know, she'll spend a bit of time smoothing everything down. I think it's a great idea, you know, especially if you've got lots of little cells. That's why this case was a good case to show, because Really is. It takes a bit of time to get that all right. And if you said to me, oh, don't worry about that, I can tell you, you'll get a perfect cavity and then you'll get a funny little reaction just happening in that pocket if you don't make sure it's exposed nicely. Oh, I stripped it. No matter. Here you go. There's the anterosmoidal artery at least. And you can see how there's a whole little pocket up there, right? So obviously without stripping in real life, take your time, thin out the edges. And here we are now. And look with my 0 degree how I can see the front wall. Give me a curette. And for most people, if you've done a Carolyn's well, you should be able to put a curette and touch the apex of the frontal sinus. Now, again, remember, we're using a 0 degree, right? So there's our apex there. And now, I've entered the other side here, right? So there's an intersinus partition cell here. This obviously drains to the other side, so we'll see it when we do the Lothrop. But your choice is yours. If you want to quickly connect all of this and make it almost like a hemi-Lothrop, that's fine. We're going to leave it for the other side for now. But that's really the opening that you're looking for. And then we'll put this flap back up. And then you can see how well the Woodworth flap covers everything. And then really, we use a little free graft through here. This has all got mucosa. There's a bit of funny exposed bone here that maybe in real life I might drill that down just to make less of bone. It's sort of the floor of the frontal sinus. And you can see you've done all that. There's no need to sort of chop the middle turbinate and doing everything. And it really just becomes this cavity, this single cavity, as if you had like a big favorable cavity. And importantly, looking laterally, you should be able to almost see, you won't be able to do anything on the orbital floor, but you should be able to see, if I just take a little bit of this bone off, there it is, the roof of the orbit. Can you see that, Simon?
Yep.
Yeah, so that's the roof of the orbit. Now, someone said to me, oh my gosh, Richard, you'll probably never need to do a Lothrop again. That's not true, actually, because when you do a Carolyn's, it is actually very limiting. You're just making this vertical box or corridor directly up the top. And I can't tell you, this is great for inflammatory disease. You want to see the skull base. You want to get access above a lesion. But if you've got something happening in the frontal, look how my instrument is hopeless. There's no movement. So I don't recommend, if you've got frontal sinus pathology, trying to do it through a Carolyn's. Carolyn's is really a way of doing frontal sinusotomy, and connecting it all up with the rest of your sinus cavity.
And people have asked, is this just for revision cases?
I don't.
No,
this is how I do my primary frontals.
And it doesn't take, you saw how quick that was. It really adds an extra 5 or 10 minutes max each side.
Oh, you mean to remove the bone?
Yep.
And I think it takes 5 minutes to remove the bone, and it saves 40 minutes on the dissection, for some people, especially if they've got a lot of pathology in the sinus cavity. Should we do the pre-lacrimal, Simon?
Yeah, just a quick question. Someone's asked about the disadvantages of the intact bullet technique.
So I really don't promote the intact bullet technique now, and I give great respect to Sethi and PJ when I say that. I know they've taught the intact bullet technique. The intact bullet technique creates a very tight surgical field for the operator. It places the operator working in a tight space, limited landmarks, and all the sinus anatomy still with them without knowing where the boundary is. But the advantage of the intact bullet technique is it certainly protects the surgeon from the skull base, Simon. But to me, it's like learning a technique where you don't put your instruments more than 6 centimeters in the nose. While that's a great technique to preventing skull base injury, and some suckers still have the markings on them to understand how deep you are. I think leaving the bulla intact just to stop you from getting in the skull base or into the anterior artery just becomes very limiting. Now, that said, though, if you're doing an OMC operation and you just need to quickly open the frontal because you don't want it to scar or you think it's going to scar iatrogenically, I think it's a great technique, if you're just doing something limited. But for me, if I'm planning to have a big cavity like that at the end, I'll just find the anatomy, from the very beginning. And I think even my colleagues, PJ Sethi, will say that it was a fantastic technique to use before the days of IGS and other phenomenons. What do you think, Simon? You think my
Well,
take
I
on
don't
it's fair?
do it. I don't do intact bulla anymore.
Yeah.
And I increasingly, regarding this sort of approach to sinus surgery, a bit like the otologists who find the facial nerve early during their mastoid, because once you've got the anatomy, you know where the danger areas are, and you can see them. You don't have a problem anymore because you're not going to go outside those. Question about management of the flap after you've done the flap, Richard. How do you secure the Woodward flap?
Yeah, so I put a silicone sheet in here, and I use a glove spacer where the glove spacer, the front edge of it sits on here, up here.
Yep, holds it in
place. The
place.
spacer sits here, runs all the way back, and the front edge sits over the top of my flap here. And if you really, you can stuff something like some nasopore in here if you want to, but most of the time, a very long glove spacer will work.
And so the glove spacer is literally a finger of a surgical glove, and you put Mericel at the middle of it?
A Mericel pack in it, and a very long one, 8-centimeter one. Because the sinus cavity is long, and I want it to stick anteriorly over the top of everything. So it's quite a long flap.
Do you make holes in the glove spacer? So
no,
that things can absorb into the Mericel?
Yeah, I just leave it intact. I think there was a time when we used to do things like that, because we used to put steroid and things in the glove spacer. I think though that helps, to some degree. So, if you want to do it, that's great. But I don't think it makes a huge amount of difference. I think that the clinical benefit's relatively minor. I think if you really want a lot of steroid effect post-surgery, because you're expecting a lot of swelling, just use some oral steroid for a short period. Now, here we're going to make the pre-lacrimal, right? Now, once again, in the pre-lacrimal, I've seen some people describe a technique where they made a little cut and then spread it, Simon, and then try to get through here.
It's too tight. You'll tear it.
And the problem is that is a great way of leaving yourself with a big perforation at the end of the case. What you want to do, in my opinion, is you want to create this big flap. It's anchored back here and anchored back here. And always in dissection, do things posteriorly and inferiorly in the nose. So we'll do the floor flap first, because I don't want to, if I did the anterior bit, it might bleed down onto me.
And where's that anterior incision? How far forward are you?
Same as the lateral wall flap, right to the piriform.
Yep.
Right to the. There's no point making it smaller. It doesn't make sense to make it smaller. The only reason people make it smaller is because they lack confidence to make it bigger. The bigger you make it, the less swollen it gets, and the more it's forgiving, because it does retract a little bit, this whole flap. So the first thing you want to do is you want to raise this. Raise the inferior bit first. Stay on the floor. All the way back, and you say how far back? To the head of the middle turbinate. Then you come up here. Then you want to raise this one up here. And you can see
again, that's right at the edge of the piriform aperture.
Exactly, right at the edge. And you can see when I dissect, Simon, this is the other thing, right? It's almost you see my cottle stop, and it stops because I'm pushing on the bone and coming up to a little ridge, and I'm working out, am I still in contact with the bone? Because the reason it's raising nicely is not because I'm pushing the soft tissue, it's because I'm staying on the bone. And if you stay on the bone, you'll always be good. The only time you get problems is when people start to do this, Simon.
Yep. And then you're going to tear it.
And then you tear it, and it splits, and you don't know where you are. Yeah, so it's always, always, always. So you can see as I do this now. Now, for some people, they have very, very big turbinate bones, and so you're going to have to dissect the turbinate bone out in some people. Some people, it's so thin, it can just sort of almost crush back with the rest of the soft tissue. But if it's big, you'll have to take it out. Well, I'm not sure what this is going to be yet.
And you can see that ridge where the inferior turbinate bone attached to.
Correct. But very quickly, you'll find this. You'll see the mucosa going up here. There's a little bit of a turbinate bone here. And if you had a big turbinate bone, you just pluck it out, because it does stop you folding your flap back.
And so the name pre-lacrimal is probably a misnomer, because we're perilacrimal.
Correct. That's 100%. So give me a curette now. So that's going to fold back, and you should be able to fold it back like that. If you fold it back, the bleeding edge gets out of the way. Now we'll have a Blakesley after this.
You mentioned IGS earlier on. Do you routinely use IGS, Rich?
I don't routinely for most cases. Yeah, because I like it. I think it's very useful. I think some complex cases where you have trajectory planning, it's becomes essential part. But IGS is useful, it's a great teaching tool, but in my opinion, it should never be essential. Yeah. So here we go here. So now you can see here, the mucosa is heading up here. So with the Blakesley, I'll just take this little ridge away. Can you see us? This little ridge is going to go. And by taking that little ridge away, we've exposed the bottom of the lacrimal. So give me a kerosene up.
Just some other questions about your finger cots. Do you suture those in?
I do. I put a little 4-O-proline and I suture it to the septum. Not because I'm worried it's going to dislodge. It's really so I just got something to grab when I see them post-op. Because, you know, not all patients are the same in terms of how well they do post-op care. And some of them come back and their nose is so bloody and crusty.
And how long do you leave them in?
Yeah, somewhere between 7 and 14 days.
So 7 to 14 days, you take them out.
Never less than 7.
And post-op irrigations following day?
Yeah, the following day. Kerosene up.
Yep.
So here we go. Here's our nasolacrimal duct, the membranous duct, and it's almost like a DCR. We'll see when a DCR you start back at the lacrimal bone, but here we're starting right on the anterior wall. Can you see that? And really you can see this this membranous duct. And if you put your kerosene in, just like PJ originally taught, you know, doing DCR, you know, wiggle it in so you protect the mucosa of the duct. You know, I think they describe using a Hayjack-Koffler punch. We're using a 2mm angled kerosene. So we'll quickly go up here. And I take this as high as you can because you want to be above the orbital floor. And the orbital floor doesn't start until where the sac starts almost. So,
and if you don't remove this bone over the duct, you'll have such a small opening.
Yeah, and it won't swing either. This is the next thing about your comment about Blakesley, about is it pre-lacrimal? It's not really pre-lacrimal, right? So doing a pre-lacrimal approach does not imply you need a pre-lacrimal recess. It's around the duct. So give me a curette now.
And by moving the duct out the way, it avoids a lot of the problems which have been mentioned in the literature about the pre-lacrimal is only suitable for certain patients.
People, yeah, 100%.
So you're creating more space. So that group where people say, oh, there's not the space to do a pre-lacrimal. Yes, there is. You can make that space.
Yeah. It's a misnomer on the concept. And I don't think Bing Zhao, who described it initially, right? We have to shout out to Bing. You know, he's the guy who really promoted this. Just down in Adelaide many, many years ago, and I saw him talk on it. I thought that's a fantastic concept. And Bing, you know, great job. But he never saw it as being, oh, you've got to go through the recess. It's about you're coming anterior to the lacrimal lap system, and that's why it's called pre-lacrimal. And you can see here that in that dissection, I've really pulled now the whole membranous duct out of that area. So let's go now.
You've almost doubled the space.
Yeah, and that's where I'm going to enter. Give me a Blakesley and put the drill on for me. So let's push our flap back. So the nice thing about making the flap big is it'll fold over nicely like this. Still a little bit of bone. You can see by taking the bone out, it helps soften up this front bit, and you can allows it to fold over. There you go.
Someone mentioned, do you ever need to go transeptal in the Carolyn's window to get further laterally?
Very rarely these days, I must say. I don't say, I never say never, right? Because I think there's always circumstances in which you need it. Now, I think this is the next one that's really important. So the most important thing is that you've come right to your edge of your piriform, Simon.
Yep.
The next thing I do for everyone is I'll very lightly brush back this area here. This is so important. You cannot do it without lightly brushing this all back.
That ridge gets in your way.
Gets in the way. And the other thing too, if you can, find your anterior superior alveolar curve early.
So have you medialized the inferior turbinate in doing that? Did you actually medialize the inferior turbinate?
No, it's just
nope.
push. I just folded it back.
Yep.
So here we are here. So you can see how there's a bit of soft tissue coming up in here. And I might get you to help me with that whippersnipper. We call it the weed whacker, the whippersnipper. See where I've got stuff on around the apex. Give you a curette while we're waiting. Sorry, I'll take it back from you.
This is the same drill you used for the Carolyn's window?
Exactly the same. We only use one drill, yeah. So I think here we might be coming up to a bit of soft tissue. We'll have a look. Let me get a nice view, Simon.
The other thing you were mentioning was the the apex of the drill. If you think that the drill rotates around its axis, so you're actually getting faster speeds, more efficiency on the equator of the drill.
Correct.
The
Yeah.
further you go away from the equator, the less efficient it becomes.
And you want to see this wall. I'm drilling slowly here because I'm trying to show you the anterior superior vela nerve.
Yep.
That's it there. That's soft tissue there. So we're going to call it for that for now. Okay, so once you know that, or you've called that the anterior superior canal, then you just go back to this perilacrimal, as you said, area. And we drill it. Now, there's nothing to worry about here. You have to make sure you get rid of Snidvong's wedge, which is this little wally thing down here. We'll talk about that later on. And then you just remove it. And I can't tell you how straightforward it is. Very straightforward.
So the meta-analysis Richard and I were talking about earlier on, there was a nice meta-analysis on pre-lacrimal published by the Zurich group in rhinology last year. And in the meta-analysis of over 600 cases which have been produced, there was a 12% prevalence of some form of facial numbness, but 3/4 of those resolved within the first 2 weeks. So the long-term risk of long-term facial numbness was 3 or 4%.
Now, I'll get you to unblock that. So just see, here's a really good example. Just release my sucker for me. This is a really good look at how important it is to get that anterior bit right? Some people have different shapes, so you can still see there's a bit of bone here, but you can see how important it is for us to go high here, Simon, because I need to remove all of this to see the floor of the maxillary sinus. See that? See, now I can see the floor of the maxillary sinus. Do not do this approach without seeing the floor of the maxillary sinus, right?
Well, often you've got to, because that's where an inverting papilloma or your pathology actually is.
Poke it through. And of course, I drilled with the pole of the burr there, so I stuffed it for Ling and got a little plug of mucus or something. Here we go.
So would you use this for an inverting papilloma? There's a lot of criticism you can't see the cavity afterwards.
Yeah, well, it depends on how much area I'm going to create for remucosalization. So if I have a little papilloma here with a small base, I'll do it. But if I have a giant base here and a lot of the area needs to be drilled, I will do a medial maxillectomy, which we might show next, right? So here we go here. So take this off. This is the rest of this.
You always do a wide middle meatal antrostomy just so you can use an angled scope post-operatively in a...
Yeah, I was going to say always I do a medial, a middle meatal antrostomy because you need to be able to irrigate the cavity. That's a really important concept. You can't do this approach and not set the cavity up for irrigation. Like you can't rummage around in the sinus cavity and then suddenly expect it all to heal well. You got to open it up for irrigation.
Can you combine this with the medial maxillectomy?
I don't think it's just convert it to a total.
Yep.
If that was the case. Yeah, I wouldn't do that. I just would convert your cavity to a total medial maxillectomy. A total, yeah. Because the modified bit is just about keeping the whole thing intact.
So can you point out Concat's wedge again?
Yeah, I'm going to point it out here. It's more important, I think, when we do the other head. To show you. Give me a big wash, thanks. Let's give it a bit of a wash out. But now, this is the approach, right? So I haven't done an antrostomy here yet for this. We'll convert the other side to a medial maxillectomy, and that'll give us a good access. So give me a curette now. So this is really important. So Snidvong's wedge is this bit of bone here, right? If you don't take this off, when you put instruments in, see how they touch everything? See that? So you've really got to take this wedge off, otherwise you can't get the instruments in, down, especially down low in a medial maxillectomy. There's the V2 nerve coming forward. And here, remember, I'm using, Simon, a straight scope.
Yep, you can see that anterior wall.
You can see that anterior wall. Here's that partition. You always got to be careful when you're dissecting tumours off around this. Remember that the nerve sometimes does lie low before it exits out the inferior orbital foramen. And look, I have no problems. Hit us up with a 70-degree scope. This is where I sometimes will use a 70. And Simon, you said to me, how often do I do a transeptal? Not so common anymore. I'm essentially doing it now only if I can't see a pre-lacrimal and then I put a 70 and a bit of angled dissection and I'm still completely miles off from finishing it. Give me the frontal one. But really, I've got an angled scope on now, and if I got close, Simon, I think I'd be happy. And I did a case this week where we were working on that side of that infraorbital nerve. So in the lateral compartment here, out to the zygomatic recess, there was a bit of tumor and chasing it there. But normally I can do that with an angled scope. But then I'm doing 10% of my surgery with an angled instrument, not 90%. And you're certainly not doing it through the opening. So here's a fascinating thing to see. So we're going to go in through our opening here. And I'm going to show you as we turn around. There is the fontanelle. There's the floor of the maxillary sinus. There's the fontanelle. It's miles away, the antrostomy from this front bit. I think maybe the 0 shows it better. You know, because I think once you do these sort of approaches to the maxillary sinus, you understand how limited anything performed through an antrostomy actually is. So, let's get... So here's our opening. There it is there. But look where the antrostomy is. It's way over here. You know, it's miles away. It's just night and day difference. Now, because I've got this is about the opening you need to actually do real surgery in there. But because you've made the flap the way you've made it, it does then completely cover the area. So the first suture I do, give me a small tooth. The first suture I'll do is to pick this chunky bit of the head of the turbinate and suture it back to here. Then I'll do maybe 1 or 2 up the top, and then the floor here. Now the reason we do this is it's not because we're trying to preserve the inferior turbinate because of empty nose or something like that. I mean, empty nose syndrome is about patient selection for surgery, not what you do in the nose. But we want to do it because it gives us gives us great access. It returns the mucosa for very rapid healing, and make sure that we've got a very quick remucosalization there. But as Simon pointed out, it does mean that you've got to do an antrostomy, and then you have to make a decision about how big an area what wound do you have in the maxillary sinus? Yeah,
question about that sort of drilling that anterior maxillary wall. If you saw that it allows that flap to sit better, so you're going to get less contractures. Someone's asked, that's exactly right. And we mentioned the post-operative management. That's exactly why, you know, if you've got something that you're worried about a recurrence, the pre-lacrimal is difficult to look into post-operatively, and that's where you need to consider whether you would just do a medial maxillectomy for better post-operative access.
Okay, should we do the modified?
And suturing the flap, someone's mentioned?
5/0 Vical repeat.
Yep. And where do you put the needle first? Because it's technically quite challenging.
Give me oh my gosh, Simon's going to make me do it live, right?
No, I'm not. I'm just going to say, where do you put it? Because it's not straightforward.
No, you're 100% right. See, so let me show you. This is it's a PDS, is it? That's fine. Don't worry. So I don't have a range of suture material, but no, that's fine. But even Ling is going to make me struggle here and show me. Okay. Now, so what I do first is pick the chunky bit of tissue to do first. So you want to pick up that turbinate head, right? That turbinate head is always the easiest tissue to do. So you can see the head. You see how I reverse cupped it?
Yep. You need a big bite.
And then I'm gonna do it again. Don't be afraid to do it in 2 passes if you're doing it for the first time or you're struggling. Give me just the white.
And then you take the anterior.
Then you get a nice bite of the anterior.
If you try and do it the other way around, it is almost impossible.
So you can see I've reverse cupped it. Now, if you can't quite see your suture, you're going to press a little bit, and then you can grab that.
Great. It makes it look very easy. It is anything but.
Yeah, but that's my only tip. Tips and a bit of practice. Especially when you get made to do it live.
Do you see collapse of the alar externally after a pre-lacrimal approach? No.
You never do, because you're entirely behind the piriform.
Yep. So you need to keep that bit of bone. You saw Richard identify the anterosuperior alveolar nerve. You obviously don't want to go forward from that, and that keeps your external contour.
Okay. Give me a curette.
So you're preserving that bit of bone at the piriform aperture.
Okay. I actually tied it for everyone so that you could actually see what it ends up looking like. And I do the first one nicely like this. This one's the trickiest, if you ask me, Simon, to put it through to here. But once you've got one in, you can often do the other ones with a single pass. You know, you just go through here.
The one on the floor, I often just put some Silastic on and leave it.
And look, sometimes you're absolutely right. If it's too friable and I think I'm going to tear it, Silastic and a bit of Nasopore just to sort of push it back is the other option. But you can see, you know what? I reckon if you did this and a bit of Silastic at that one suture, you'd probably almost get away with it. Okay, so let's go now and do the opposite to this, which is this concept of just removing, rather than trying to restore the lateral wall, let's just remove it. Now, the first step in removing the lateral wall of the nose to get access to the maxillary sinus, because it really is an important skill. Every surgeon should know how to remove the medial maxillary wall or the lateral wall of the nose. Let's go at artery clip. And what I'm going to do is I'm going to crush the artery using an artery clip. I'm going to crush the inferior turbinate. And we're going to do, first of all, what's called a modified medial maxillectomy. So there's the head of the antrostomy up there. So I'm going to make a little cut like this. Give me the medicine balm next.
Someone's asked about inferior meatal antrostomies.
I don't really do it. I can't do much through an inferior meatal antrostomy. And I do think I set my patients up for weird mucus recirculation problems if you do things like that. So I mean, the nose is very forgiving, so you will get away with a lot of that. But I don't do it. Now what I do here is then I take this, I intentionally preserve the mucosa of the middle meatus. Now, as you come back here and you're going to take away the inferior turbinate, leave a small soft tissue tail. Blake, see, Higgs? Only because you will have a little vessel there, and it's good to have something to bipolar and coordinate it. Now, keep that mucosa. It's great mucosa for future grafts and various things. Okay, so here we are now with a sickle knife, thanks. I'm going to make my cuts. Now, making my cuts posteriorly. Feel for the hard palate, soft palate junction. This back cut in a medial maxillectomy is very close to either the back wall of the maxillary sinus or the hard palate, whichever is more anterior. Then you make a completely perpendicular 90-degree cut. Now, obviously, I'm trying to scratch it out with a sickle knife, but in real life, I'll use my...
But with the needle point diathermy, it's a lot easier.
Yeah.
Yep.
Give me a... I'm starting to strip
and
it.
the reason to go...
Give me a...
this far posteriorly is because you need that flap to roll in at the end, which Richard will point out.
Yep. So you only need to make one 90-degree release. You can see I'm right back close to the... Good, perfect. Give me the sickle again. And then the anterior one, you make coming. You should have a look and see where you're... In real life, that's probably the nasolacrimal bulb just there. So you want to come just in a modified medial maxillectomy, because the term modified, tuna saving, preservation is just about preserving the lacrimal membranous part. If you preserve Hasner's valve, you just avoid someone getting air escape up their lacrimal system. But you've got to be careful here. Just because you destroy Hasner's doesn't mean someone's going to get lacrimal regurgitation. There's about 6 or 7 different valves, aren't there, Simon?
Yep.
Now, this one here, though, is not 90 degrees. It's 45. Look at the direction I'm coming. Simon, can you see that?
Because you need that anteriorly. Correct.
Yeah, this is the error people make. And I'm coming right to the piriform again, right? This idea of coming all the way to the piriform when you do it. Now, give me the caudal dissector now. So now when you want to raise this flap, you want to do it where it's firm, which is usually the floor. And as we come back here, there it is firm, nice to the floor, and then we're going to come up here.
And the wider the base of that, the better it's going to heal,
correct.
the less likely you're going to shred it.
And come all the way anteriorly here. You can see I almost took it. There you go. Because I'll show you why it's so important. And it's so good to have cut it properly with a diathermy. Give me the caudal. And then I really then fold that flap up against the septum and I will take it right across to get it right out of the way.
The last thing you want is that getting caught up in your drill.
Correct. Or your sucker. Just putting the sucker in all the time, it becomes frustrating. Now, give me a curette. So the first maneuver I do is what we call Jess's punch. Oh, Jessica Grayson, you know, no messing around, right? You just want to get in there, just punch it straight through. And the reality is that you're just punching where we used to with the kerosene up. We used to do tree fines, you know, back in the day. Antral, you know, with a tree fine cannula for an antral washout. So you come straight up, and then I'll often go straight down with the down kerosene. Oh yeah, change the shaver, but we'll use a straight through cut. Okay, I don't really have a down, so I'm not going to pretend to use my up as a down.
My first ENT job, we had a clinic where all we did was sinus washouts with trefines.
Exactly. So here we are now. So now what you want to do is you want to just, we are going to use a shaver, same crunch and gobble technique. So we very quickly just gobble it all up. So I use my little all the thin stuff you can get rid of very, very quickly. And then I'll go backbiter here in a moment.
So needle monopolar, what power do you use?
12 and 12 on a Covidian system.
Yep.
They're all pretty similar, aren't they? Valley Lab, Covidian, 12 and 12. Pretty low, right? Not because I'm worried about transmission or anything else, but just, you know, burnt tissue doesn't heal well. Now, can you see all this raw bone? You want to get rid of all the raw bone with a backbiter right up to where you made your incision with the mucosa, right? And I tell you, when you do it with the needle point, it's very easy to do, right? It's super easy to do. Now,
do you ever get any palatal numbness?
Say it again?
With that flap posteriorly near the hard, soft palate junction, do you ever get?
I think only if you hit that. See the greater palatine artery, and the nerve will be right behind it.
Yep.
Shaver, thanks now. So let's gobble up things that we've done a very, very comprehensive biting through of everything. So we'll just tidy it up, Simon.
When you do the Carolyn's window, do you ever resect part of the middle turbinate, or I mean?
Yes, I very commonly will resect the transition. We might show that actually at the very end. That's a good discussion to creating a neosinus cavity. Now look here though. This is a great. We'll use the drill here in a moment. So here we are now. So I get offended by all little bone flakes, right? So let me.
This again, where washing it out on the table helps get rid of all the fragments.
Correct. And then here, you just want to leave yourself a little stump of bone. Okay. So now give me a drill.
Do you use hot irrigation or cold irrigation when you?
While waiting. I use warm irrigation if I can.
I think there's some evidence it's hemostatic as well.
Yeah. I only get it though when I'm well behaved. If I'm being pleasant to people. Ling will get out the warm. Otherwise, I don't get that service. So here we are now. Here, can you see this wedge? This is Snidvong's here.
Yep.
This is Snidvong's wedge. If you don't remove it, you just can't. You sort of or your shaft. See, your shaft is hitting, and this one's not so bad, you know. So let's now show you what we do when we.
Because often the maxillary floor is below the nasal cavity.
Okay, here we go. Okay. So I don't do anything posteriorly. The first thing I do is Snidvong's. You've got to get Snidvong's wedge all the way down to the floor. And you can see here, there's obviously some sort of little pre-lacrimal recess, you know, that I'm coming into. So it goes to show you what I'm missing. Yep. In a medial maxillectomy. Can everyone see that? That's mucosa in the pre-lacrimal. So I'm missing it all because I've left it all intact. Can you see that? So that's mucosa of a pre-lacrimal space. That I'm not going to see. But by removing the wedge here, I'm going to get all of this exposed. There you go, Simon. So I can see a tooth root now. Now, very quickly, you want to get rid of this bone. But as it gets thick now, at this diamond at the back, this is where you've got to slow down, right? Because this is where you'll end up picking up the greater palatine canal.
Yep. It's about temperature of is preferable.
Don't know. We've used that drill too many times. Okay, so one thing, you can actually see the nerve here. You can't normally see the nerve, in my opinion.
It's a nice view, actually.
That's the tooth root there. Don't worry about drilling. If you drill a tooth root off, that's fine. Give me a Blakesley. The tooth gets its blood supply from the periodontal ligament.
Odontogenic cysts and things, which approach...
Great approach. This one's great approach. Pre-lacrimal or this one. Now here, when I get towards the end, if I really want to push it, because say I've got a real problem and I'm trying to get access, I'll grab this last little bit and twist it. And by twisting this last little bit, it naturally will often fracture at the level of the greater palatine canal. There you go. See it just go then? See how it's fractured at that point. So if you're worried that you're getting close, don't use the drill all the way up. Grab the last little bit and fracture it off. And look how it just naturally starting to cleave. And
it's
you're
a nice
much better
demonstration of the nerve and the vessel.
It's a good one, yeah. Right? So you're much better off to get this exposed than damage the artery. You know, I've not really ever seen people with problems just exposing the nerve. It's when you traumatize it, when they get pain and numbness. Okay, but there. Give me the drill now back. You can see this is a little bit too full. Now, this person does not have a significantly pneumatized maxillary sinus. There's my thing about sucking the flap. But what I do, give me the ball probe. If someone has a deep sinus cavity and I'm doing a medial maxillectomy, not sometimes, but every time, I will take the mucosa off the floor here. So I'll strip it away. And usually when it's inflamed and thickened, it's very easy to strip. It'll be harder sometimes to strip it perfectly when it's all thin like this. You know, I guess it's easy to get it started, but getting it nice and clean, it doesn't strip nicely. But I will intentionally strip all of this off. And in this patient, you probably don't need to, but in a patient with a deep sinus cavity, you don't want to leave another deep pocket over here. This from a functional perspective, will leave behind a bit of a sump. So we'll strip the mucosa off, deal with whatever pathology, and then with a caudal dissector, the flap that we've created goes over the top, like that, right out to the outside wall. And so you get this great coverage.
And that's healthy mucosa replacing the diseased mucosa.
Healthy mucosa. And if it's really, really deep, I'll even leave some gel foam underneath the flap in this dead space, and then the flap goes over the top, so that I'm actively obliterating it, so that my final cavity has this shape. This shape's got a perfect final cavity because the floor of the maxillary sinus is already at the level of the floor of the nasal cavity. That'll really help you. You bipolar this, of course. Fold this over or tease out the bone so you don't have stuff in there. But doing that will really help to ensure that you don't end up with crusting and things happening over here. And you just want to go back and make sure your front edge looks good. You can see there's a bit of bone sticking out. You'll trim all that out. And give me a 70. I'll take with a 70-degree scope, and we'll have a look here at the difference in view. So I think, you know, when I first started sinus surgery, I thought, oh, you know, you'll see now an enormous opening into the maxillary sinus. It's just a simple ball probe first. But you'll see here, the medial maxillectomy, or the modified, has not given me anywhere near the same view as the previous pre-lacrimal. So here's that little bit of bone. There's a little space through here. There's a space behind it. So there's a whole pre-lacrimal pocket that I can't really see, and I can only really see half the nerve. And I've got a 70 on now, right?
Yep.
So it goes to show you there is a role for each. One is, it's not either pre-lacrimal or modified medial maxillectomy. I think it's got to do with where your pathology is, what you want to achieve, and everything else. So even taking that off, I still can't see the front wall. There it is there, but I certainly can't even see up here. And I got a 70 on now, so I can't really do much with that.
If you've got an inverting papilloma, do you use an MRI to get site of origin before so you can plan?
No, I tend to, if I can get a feel for where it is, I'll judge it. There's a few pre-lacrimals I've started and just converted it to a total maxillectomy.
How do you deal with pre-op consent in those cases?
I don't discuss the technical nuance for patients. I tell them the more broader issues with, you know, the complications around the procedure and what's the natural history of the disease. I don't really go through technical aspects of the surgery with patients unless they show interest and really want to know. So I do what I think is going to be the best, and I think most patients want me to make the professional judgment there of what's best. But I will talk to people about dysesthesia and things like that. You can get it doing either approach, Simon. You know, you can get the greater palatine canal and nerve is more at risk in a medial maxillectomy, and the anterior superior is more at risk in a pre-lacrimal.
So someone's put gel foam underneath the flap, yes, to get rid of the dead space.
Yep.
So and that will just absorb and then produce a little bit of scarring.
Granulation tissue.
And it just it's not a problem. Now I know that in your sinus course you've moved very much to a pathology-based approach. Someone's asked about diffuse nasal polyposis, post-operative oral and topical steroids. What's your normal approach? Say someone's got T2, diffuse chronic rhinosinusitis, high eosinophil count. What's your post-operative management?
Well, let's go back to the other side then, Simon. Before I start, because I was just about to do a lateral wall flap here.
Sorry. Yep.
Just to set us up for the Lothrop, right?
Yep.
And then, but I think because there's a couple of nuances there about the idea of creating a neosinus cavity, right? I like creating a neosinus cavity. I think if you take a big papilloma out of someone's ethmoid, you want to create a neosinus cavity. You want that sinus cavity to work. You want to make sure that they don't get problems in terms of trapping of mucus. You want to be able to look after it. You want to have a cavity that you can surveil the area for recurrence over the years afterwards. So I still think we do a lot of neosinus surgery for a lot of things, right? If I do a CSF leak like here in the ethmoid, I want to make sure that I can get access to the defect. I want to make sure that I can lay my graft over it without blocking the frontal or the posterior ethmoids, creating secondary sinus problems. So I still do neosinus cavities for a lot of interventions. Orbital decompression, Simon's another one. You know, if you want to now decompress the fat, you've got a sinus cavity that's not going to become dysfunctional from the fat sitting in it. But let's go back to your question about inflammatory sinus disease. So very typically, give me a Metsen balm. For a lot of patients who have, like this guy here, has got a very bulbous bottom end of his middle turbinate, you can see where we've preserved the superior turbinate back there. I will very commonly take this bulbous part off at the same level that I've trimmed the superior turbinate. And it's back here that your smell cleft is at. And then give me a Blakesy. And I'll leave a little stump here that I'll bipolar. And I do this for inflammatory disease sufferers because it preserves the olfactory mucosa. You should be very careful as a surgeon as ever taking olfactory mucosa. You know, like when I was younger, Simon, a surgeon once said to me as he was doing a polyp operation, said, "Oh, don't worry about the smell because this patient will never get their smell back." Well, sadly, you know, within my lifetime and career, that very patient that I saw operated on, you know, there are treatments now that we get all their smell back. You know, so, you know, that person, by having the surgeon dictate smell loss by cutting a smell cleft, means that when the treatments eventually became available, that he was no longer going to benefit from them. So I really preserve smell. I want that superior turbinate, middle turbinate to be cut at that sort of level. You can push this back a little bit if it's a bit too far forward, and this one might be a slightly bit, so you can take that back. But then I just leave this vertical strut, and it's like a box. It really is a box. It just means if they get a bad flare or cold or something else, they do very well from having, you know, just this box. You can always salvage them. If not in the clinic with a course of steroids, they'll come back to normal. I'll place this graft up here, this flap. I'll put a free graft across this area here, put my glove spacer in, and I'll put my silicone sheets into this sort of smell cleft that we've preserved here. So you can see the whole smell cleft all the way down. Look how much smell cleft has been preserved, Simon.
Yep.
You know, the whole thing, retronasal smell, anterior smell, everything's been preserved. And the silicone sheet will make sure that there's no adhesions. And can I have a freer? And if there are adhesions in there, get rid of them. So using the blunt end of a freer, if you see adhesions, place your freer above or below, and slide down and divide them all.
Yep.
The little adhesions you find in the olfactory cleft are actually thought to be acquired during our lifetime. They're thought to be less common when we're younger, and we acquire them through things. So do slide through it, and then place your silicone in. And then I usually don't give much more than about 2 weeks of prednisone, 2 to 3 weeks of prednisone, Simon, because very quickly I'll send patients onto biologics, or they will have already started them if they're already a revision case. If people have mild disease, I might use 2 or 3 weeks of oral corticosteroid. In that time, I've got them through the first 1 or 2 post-ops, and they've started a corticosteroid irrigation just once a day. No one does anything more than once a day, but they'll start then once a day. So that's how.
So when do you start them the post-op steroid washes?
Not until they come back and see me.
And what medication and what dose?
In Australia, sickle knife. In Australia, we use mometasone, budesonide, and betamethasone, and it's really just got to do with what options we have in terms of, on our PBS, and just in our market. But they're very common ones. I certainly use. I don't use pulmicort nebules very often. That is not so common in my practice, if you ask me.
I've had a couple of people whose glucose control has gone off on the Pulmicort, so I'm like you. I use mometasone.
Yeah.
I use a 10 milligram per mil gel made up by a compounding pharmacy, and half a mil in the wash bottle.
Yeah, there's a lot of contemporaneous compounders and things that'll do it for you.
But the one thing that I've also had is I've had people when people have used commercial dermatology preparations, you've got to remember that those preparations have all sorts of other chemicals and preservatives in, and you can actually cause cholestasis and problems with those commercial properties. I know some people love them, using sort of Betnovate creams and things like that, but I personally steer clear of them.
I'd be careful about the creams. Yeah, you've got to use water-soluble ointments if you're going to do it. Hydrogels, OV creams, things that are water-soluble. You can't just pick any one. Yeah, I completely agree. Now here we are now.
Bolgerization, someone's asked about.
I don't use bolgerization at all. To me, that is a recipe to create anterior conductive smell loss, so I don't bulgerize. Here we are now. So here we're going to dissect down, and we'll find as Simon once said, that you often have a little vessel here.
And it bleeds like crazy.
So you can often, that's usually not the first olfactory neuron, and then the olfactory neuron is just behind it. And then you can see that there's the olfactory neurons behind it. But sometimes you can have a real big vessel. It starts out here, doesn't it? But that's what the olfactory fascicle looks like as it goes through the skull base. It's got these little, channels that head up there. Now, we did that because we are now going to, give me a kerosene, make our window.
So saline washes post-operatively for how long? I mean, until the patient is under control, I think is the answer. If you've got a patient that comes back at 3 months and they've still got inflammatory disease, they're often on it lifelong. Yeah,
no, we should be really honest that most people who develop inflammatory sinus disease get it for several decades of their adult life, or if it's allergic invasiveness, for many, many years. So the idea of I stop at some stage is like saying I'm going to use an inhaler to control someone's asthma, and then when they're good, I'm just going to stop it. Doesn't make sense. So you got to treat the condition. It's an inflammatory disorder, polyps. It's not an obstructive or mechanical one. So you always have to treat their underlying condition. So that's really, really important. But give me the drill, and we'll drill here. But if you said to me, how long do I keep irrigation going? Well, it depends on what the goal of the irrigation is. So Simon, to me, if the irrigation is designed to deliver topical therapy, like corticosteroids, then that could be forever. I do decrease the frequency, the maintenance. Sometimes a lot of people get down to 2 or 3 times a week when they're in remission. But if the goal is to restore or recover mucociliary clearance, then I'm going to have them do it, like in a fungal ball, until I no longer see mucostasis in the cavity. So its role then is a slightly different one. It's a mechanical one. Not one of delivering topical therapy.
So people have asked about cost and Pulmicort being expensive and the cost of compounding. Certainly in Adelaide, we've got compounding pharmacies that will charge $60 for a 30 ml mometasone bottle, which is $1 a day. So that'll last 2 months. And I know the commercial hydrogels and all those other things may be a bit cheaper, but I worry about them for reasons that we discussed just a few minutes ago. So for me, the $1 a day is the cheapest I can get it.
Yeah, I think that's about right. About $1 a day in Australia. It's amazing though that around the world it's so different. That's a philosophical issue for another time. None of those drugs are on patent anymore. So here's Ritter's triangle. So, you know, what access you have to corticosteroids. I can guarantee you, though, regular corticosteroid use topically is always cheaper than revision surgery, and it always keeps patients better controlled. You know, when patients have revision surgery, it's not like they all of a sudden are symptomatic. You know, they only come back and see the surgeon for revision surgery when they're really bad. So, you know, keeping patients well controlled, acknowledging it's an inflammatory disorder when you have polypoid formation is so important. So I'm just drilling out Ritter's triangle, and you can see I can even do the triangle without finding any other anatomy, right? And you can see that here we are here. I've got my periosteum here, and I've done half the cavity already. But I'll just very quickly now just finish off the cavity to show you what different access you have when you've done a Lothrop. And someone said to me, Richard, when you do a Lothrop, it's almost like you're just doing 2 Carolyns, and that's absolutely true. Except when you have the window, you can sort of do both sides at once, that's all.
And your dose of oral steroids is just 25 milligrams
Yeah, I
daily?
don't really give anyone more than 25.
And you taper it?
Not if it's under 3 weeks.
Okay. You're braver than me.
That's the current recommendations.
Yeah.
That's not my gestalt. Current recommendations is that courses under 2 to 3 weeks, no taper is recommended. And we're not using a big dose either, you know, at 25.
And obviously this is a cadaver. Injecting the mucosa in a real patient, what do you use in your injections?
I have an injection that is 1% ropivacaine, 1 in 100,000 adrenaline, and 100 milligrams of tranexamic acid. That's in my topical. Give me the drill back. You can see here we've got periosteum sac. Swap it out.
And all my patients get IV tranexamic acid as well.
Sometimes if you have to work around the corner, you can work from the other side. So here's the front wall of the frontal sinus, or frontal recess, I should say. But say you were struggling there to see, well, you're at a point now where you can come across to the other side, and I think you get a better view, Simon, when you come contralaterally. Because the orbit and the frontal recess does disappear laterally. And
when you're drilling easily there, you know, that vertical lamella of the cribriform plate, how are you going to, you know, ensure you don't get a CSF
Yeah,
leak?
you just make sure you stay lateral to it. Don't go medial to it.
So stay lateral, you're going to prevent the leak.
Correct. And then here we are here, that hard bone, look how hard it is. We've still got frontal recess behind me, right? Don't worry, you've got frontal recess still behind you, right? It has to be, right? Get rid of it all. You've got to get rid of it to see. There it is, slowly coming onto field. There it is now. See, I've got the mucosa. Give me a kerosene up. Give me a shaver. So I might be able, like I did on the other one, I'm going to go behind my incident. Let me get a better view. So I usually do an OMC surgery here, but it goes to show you don't even have to. But once you start fiddling with the OMC, you should open the OMC properly. Here we are here. Oh my gosh. I need that one with the detergent. Sorry, next time. Here we go here, and then here we got some sort of little shelf. Now, once again, if I couldn't get it through here, you can come across. And you can see I'm stripping a little bit there, Simon, so time to put our shaver in. Straight kerosene, get rid of some of those partitions. Let's put the debrider in now. If you can, turn the suction down. I love good suction, but I just end up stripping everything.
So it will be interesting to see how microdebriders evolve over the next few years with all the EU requirements for
Go back, please.
Instruments to be usable at least 10 times.
I meant just take the release off on me then. Okay. Now, there's a couple of things we need to do here.
People are talking about arterial ephemeral artery ligations, really not required.
It's a skull-based surgery.
Yep. So only if you're going to be going back through that area would you worry about the anterior thymoidal artery.
Yeah.
You can see it. You're anterior to it with a draft 3.
Now, this is worth discussing. The difference now between... so we've found the first olfactory neuron down here, right? So we know where it is, right? So when I drill here, I know that we're right on it, right? That'll be it coming up there. You often see the dura. That's the fonticulus frontalis tract. Can you see that? The little dot? You'll see it always as a Lothrop surgeon. That's where dermoids come from and gliomas. That connects with the foramen cecum into the anterior cranial cavity. Now, you can see I've taken that intersinus partition, but this is what a Lothrop gives you compared to a Carolyn's, the ability to really, what PJ used to call squaring off the edges.
And you're seeing over the top of the orbit there.
Yeah, and you're hugging now the orbit. And I can't tell you, you get a lot of extra access doing this. So there you can really see it.
And how high do you take the interfrontal septum?
Oh, all the way. It depends. It takes no time at all just to take the whole thing. So we'll have a look here. Blakesley, please.
And you sometimes find the 15 degrees not enough to get you right up the top?
Yeah, occasionally. And that should be more about the patient's forehead, like how strong a forehead they are. I think some surgeons think that an Asian face is not suitable for a Lothrop. That's not true, in my opinion. A nice flat nose to forehead arrangement's perfect. You can come straight out. It's the Germanic forehead that comes further forehead, like the big forehead bossing, Simon. If you said to me that's the front wall that you'll struggle, and you can see why, right? I live in Australia, first of all, with 30 or 40% of my patients are Asian, right? So I don't have a problem doing Lothrop in the Asian face. It's just that in people that have a very strong forehead that comes really far forward, it's blocked. It's just blocked.
So Draff himself would have struggled in his day.
You can't get the anterior wall. You have to use angled instruments to do the anterior wall. And so very quickly you can see I can take the drill, and if you want to, you can go one side or the other, but I don't even have to here.
We spoke before the broadcast about frontal trephines. We used to put frontal trephines in these patients and irrigate steroid infused saline through them. Really no longer necessary.
Yeah, I think we make real openings now into frontal sinuses, and I think that makes all the difference to the patient's ability to use topical treatment afterwards. Like if you were doing this for an inflammatory disorder or something happening up here, you're going to be able to completely irrigate that out yourself as a patient. And there's lots of studies, I think, Simon, now that show that although head position, volume, all those things do play a role in how well you irrigate the sinus cavity, the most important factor is size of opening.
Yep.
So yes, you can fiddle around with higher volumes, head down position, vertex to floor, but really, curette now.
Big frontal, big maxilla, and big sphenoid.
Exactly, all of that. That's the summary there. Get your sphenoid down low so that you can get to the retroclival recess with a straight sucker. So I have no problem sucking all that out. If you want to do the maxillary sinus, if you've got a problem with mucostasis, then make an opening to the floor. If it's just topical therapy, an antrostomy is probably going to be okay. And then when it comes to the frontal, Carolyn's window, I think, is adequate for most inflammatory disorders. But if you actually need to do surgery within the frontal recess, then I think you need a Lothrop. So what do you think we should do next, Simon? I think we said we'll do like an SPA Vidian and then a DCR. Is that?
Yep, that sounds good.
Yeah, because I think we've done pretty much everything else. Where are we at in timing? I feel like we've moved pretty quickly.
We are halfway there.
Yeah, right. Okay. Oh my gosh, we're going to have to take requests here. Do you want to grab the other head? Let us just swap out the heads and we'll get going. What other questions do we have?
So a lot of the other questions, we've answered most of them. Microdebriders, obviously we're feeling for people who can't use microdebriders regularly. I've done surgery overseas where I've had to reuse microdebrider blades, and that's just the reality of many countries. But you saw Richard using the through-biting Blakeslee wells, both 0 degree and 45 degree, and they really are going to be your mainstay if you don't have access to your microdebrider. And those through-biting forceps to just munch those up and then either suck the bits out or irrigate them out are certainly going to be helpful.
Look, my feeling is that most places have microdebriders available, and they are incredibly robust. I've seen places where they do reuse the blades. You can't reuse them forever, but they certainly do get reused.
And I think also
they're built so well. I think.
I remember when microdebriders first came in, we used orthopedic devices. So if the orthopedic surgeons in your hospital have got access to a chondrotome, that is actually going to be better than nothing.
That said, the modern day quad cut shaver almost never blocks.
Yes.
And the new drills that have the gearing at the tip are amazing. So I went through a phase where the shavers used to block all the time and the drills would break because they had the spiral spring mechanism. We just don't see that anymore. Let's do a left DCR. So the flap in a left DCR, once again, is up here. Doesn't have to come any further posterior to the root of the middle turbinate for most people. It's very, very high. I think a lot of people don't appreciate how high the sac can be. The next one, too, is that you can see the inferior turbinate. Can you see this mound? Does that come up well on the screen? Just there?
Yep.
Yeah, so that bulge out here, that's where the nasolacrimal comes out. So you want to be just in front of that. So if you're looking to judge your flap, you want to be in front of that area, right? So I want to be in front of that bulge. And I do this with a needle point as well, just
Someone,
like you do.
you asked about
where it flares here, that's where my cut's going to be.
You asked about requests. There's been a request about septal perforation closure. Do you want, if we've got time, we'll try and show an anterethmoidal flap.
Okay. Oh my gosh. Yep. Okay. The nuances of that. Yeah, there's quite a lot of nuances. And I have to give a plug here. So Islam Alabid is an amazing surgeon and thinker in our field, based in Barcelona. He runs a septal perforation course. It's in its second year this year in Barcelona every year in September. Published in the world of septal perforation. It's got some really great ideas. He gets together a really fascinating group of people to give that course. I went last year. It was amazing. I think I learnt a whole lot of new concepts and ideas from speaking to some of the people there. That world's rapidly changing. So if you're interested in septal perforation, then that's a great course to see. Now, so here's our flaps gone back. So I usually fold it back here. Now, give me the ball probe.
So, a question about primary inflammatory eosinophilic disease. Would you do a primary draft 3? I know we used to, but now that Carolyn's Window's so good.
Yeah, Carolyn's Windows is so easy to do. And look, some of my fellows who see me do Carolyn's Windows on both sides will say that's better than a Lothrop. And it is sort of true. So we do still make giant openings to the frontal. But my world has changed now. I don't have to manage the most severest of patients anymore because I have biologics. And so they never get to this terrible, terrible plugging stage all the time. And so I can get away with doing less. But when I say less, not a draft 3.
Yep.
Yeah. And the septal window, I think occasionally you'll get patients who get a bit of crusting around it, Simon. So and it's quicker. I just do big Carolyns, like I showed you, the neo-sinus with the slightly modified middle turbinate. So you're going to have very good access. That's to date, in the post-biologic era, that's what I'm doing. But yes, for years I used to do primary Lothrop. In
my hands where I've done the primary surgery, I'm now saving a draft 3 for a failed Carolyn's Window, and they're relatively few now. Yeah. Whereas a draft 3 where another surgeon's been in, and there's a lot of adhesions around the frontal.
I have no problems doing it.
Yep.
So here we go here. Here we go. That's the lacrimal edge. So the hard bone, the frontal process of the maxilla. joins the there's almost no lacrimal bone. If you said to me, is it? It's just that little thing there, I guess.
So for the Australians dialing in today, Carolyn's window 41705, Rich?
Oh yeah, no, 100%. Yeah, you're radically removing bone from the frontal bone. Yeah. No, because it's extended frontal surgery is the code. And,
I mean, the wording's very clear. Extended drilling.
It's a drill. So I got to be very careful. If you've not opened a drill during the case,
yeah, I know.
and you're claiming that code, that's so auditable by Medicare. That would be a huge problem, I think.
So even a Roy Cassiano Draft 3 with a curette doesn't cut the mustard.
I think if you don't open a drill and it's not on the card that you've used a drill, I think you're in real trouble, because in MBS it's very specific. The committee that put it together made it very clear that it's for drilling. So just someone who keratins a bit of bone, that's not going to cut it, I don't think, in professional opinion of our peers. Yeah. Okay, here we go now. There's periosteum come up. You can see the periosteum. Here's my front wall. And when I do a DCR, like everything we do, Simon, it's very much about making it smooth. So I never make a little hole anywhere. And I use this same drill in a DCR. I must say I don't use the DCR burr anymore. And you do want to get through. So if you have a look at this, and I've managed to block it because I'm using the pole of the burr. You want to get through to the agonasi, and see how much bone there is right now. You watch when we drill this away. By drilling more, we'll have less bone exposed, and this is such an important concept. Drill more to expose less. Yeah.
So the question about avoiding mucosal tears in septoplasty at the start of the dissection, and this attendee may have missed that, by raising those tunnels going right to the back, exposing the sphenoid rostrum and taking that flap right down to the floor, you're going to minimize the risk of a tear. And of course, you can never have it zero risk, especially with those massive spurs.
And I got a little I got a little tear on the other side of my flap, but you need a tear somewhere at the back to have a bit of a drainage hole. You'll get it enough on the spurs, Simon, don't you think? That you should try to keep it intact everywhere else. Being in the right plane and not dissecting the soft tissue, but dissecting the bone.
I know we've not done inferior turbinates, but you use the medial flap turbinoplasty.
Yeah, are we going to show that?
If we've got time, we can do that at the end.
Yeah, but let's do this, and then let's do, I think we do SPA and VIDI and all that sort of business. Now, you can see here, that's my sac there, and you can see we're about to open through the agonasi, right? Now, if once you get comfortable using a drill and understanding where all the anatomy is, you understand that all you're going to do, it's blocked, just the tip all the way, is that the only thing you're going to hit if you keep going through here is the frontal recess, right? You know that you're lateral to the root.
While you're drilling there, Richard, I just want to give a...
That's pretty good. So let's go a sickle knife.
I just want to give a quick plug for our Australia-New Zealand Rhinology Society meeting in Queenstown, 24th to the 26th of October in Queenstown, New Zealand. You'd all be very welcome. I think if we had 1,000 people turn up for that, the hotel might burst at the seams, but we'd love to see many of you over in New Zealand if you're able to join us in October.
Now, have a look here. So we've entered the infundibular space just here, Simon. You're not going to bugger up the frontal recess by working on the front wall. So you can, there's a little tiny bit of bone there, it's just a shelf. Give me a sucker. Give me a straight through cut. Straight through cut. So can you see what I meant by drill more to expose less? So by me just taking that up, you could even go more if you wanted to, right? At this point, it's not required. Give me a curette now, thanks. It's not required at this point now because at this point now, we're going to cover this with the flap here, right? So it's not necessary for me to drill more, but I could if I wanted to, right? And you can see we're starting to head up towards the frontal. But here, can you see here, this is still sac, this thing here, and there's still a bit more sac. Like, I think it only becomes periosteum here. So you can see how high we have to go when we're doing it. So let's give me a Blakesley thing.
And on the table, you would use lacrimal probes to show where the canaliculus is coming in?
We have a lacrimal probe here today, so I'll just open the sac up and we should be able to see it. But what is really important, I've worked with some great oculoplastic surgeons over the years, is to always pluck out the little bits of bone. You know, don't leave little bits of bone floating around. They cause little granulations. And this really is an operation, very robust and straightforward, but it will be done under by a little web of scar tissue. Granulation will destroy your fantastic outcome.
Do you use Donahue tubes?
Infant beaker, probably most common. Beaker tubes, and there's infant ones. So see how that's becoming periosteum just there, I think? Simon, do you think, can you see the difference on the screen?
You can, I mean, on the table, it bleeds differently.
And it just looks different. You can see the periosteal fibers versus the mucosa of the sac. Now, can you see here, there's still a little bit more to come here, right? So I would really make sure that all of this, and this is why you don't want to make your anterior incision too far forward. If you make it too far forward, you end up with a bit of raw bone. And it is hard. You can't really lay your flap over that. So you know, try to make your anterior incision just in front of where you think the duct's going to be. But I do really go for it. And like the bone at the back, you get rid of the little tiny bits of mucosa here. And as Ray Sachs, who's like the guru of nasolacrimal duct surgery, he's done several thousands, it's very important to get this bottom bit. Don't leave patients with a hole at the top of their duct and a huge big pit. So give me the blade, thanks. Yeah, the blade.
And your flaps are going to sit better.
Yeah, they'll sit better. And I don't use, that's the other thing too, is I see a number of people who do laser lacrimals and they always use an angled instrument. I find that very challenging too. I almost never do. I'll almost always use 0 degree the entire time. Give me a ball probe.
Like we said before, if you can see with a 0, why do you need to?
Give me a.
So what do you use to incise the sac? Do you use a beaver blade?
A keratome blade. It's like this little disposable sharp blade that's got a 15-degree angle at it. But you can see here, I picked it as being the top just there, and only just, right? So we'll see in a moment the common caniculus being just exposed, right? And see how I've made a cut all the way down. So, you know, give me the sickle knife. So it's easy to do the back flap. And then the front flap.
Do you use back biters for your front flap?
Yeah. Anything I can. There is a reverse sickle knife that often is many DCR trays that works quite well.
There's a Parsons push me pull you blade.
Oh, right, yeah. Is that like something you can cut back towards yourself with? Yeah, all those things. And then even I'll do a couple just so I get that edge to lie flat, you know. But look where my common caniculus is, Simon.
Yep.
It's really up high, right? That's the fundus of the flap there, right? You can see it, right? And look where the common caniculus is. I just cannot stress enough.
And that's where it fails.
Most people's fail is that they don't go high enough, and then they don't expose the common caniculus. So,
and that's why the old laser DCRs failed, is because they were going through the thinner bone lower down.
Kerrison. No, my apologies. Metzenbaum. I was trying to think about what we have. I'm thinking of Bellucci scissors and little instruments. Yeah, I got Metz here. So when it comes then to now, where does the flap? You actually end up getting rid of a lot of flap, actually. If you've come a bit low, you can always return a little bit of flap in front. So give me a curette, thanks. So you could return a little bit of flap like that to cover the bottom bit, but I've judged it reasonably well here, so I'm not going to have to worry too much about too much raw tissue there. Then I probably want to cover all of this to here. So you fold this back. You don't want excess though. Don't do it at the cost of possibly occluding your common caniculus. And then this bit, you just get rid of. Blake C, please.
Do you put anything in there to stop the frontal recess from stenosing?
Nope. No, because that's what I was saying before about when you open just the anterior wall, you're really good. Because you're not even in the frontal recess really, Simon, because for most people, you just open the front wall of the agonasa. You haven't even gone through the back wall of it, right? So the actual frontal cells are through there. If we look up, we should be a blind-ended sac, which it is, right?
Yep.
Because
got it.
So I think we're most of the time you're still in the anterior sort of line, and then just this anterior, whatever. What was the instrument that you used again, Simon? Here.
This is a Parsons knife.
What does it look like?
It used to be part of the mini FESS set years and years ago. It's like an angled. It's a right angled instrument with a blade on both sides, so you can push it away from you or you can pull it towards you. Hence, it got the nickname the push me pull you.
But it's a sinus instrument per se.
Yes, it was on the mini FESS kit that first came out back in the noughties.
So there you go. So there's the thing there. If you used stents, great. You'd want to put some gel, maybe a nasopore, whatever you like. I think there's lots of different. What do you put in this area, Simon?
Well, I put I use a circle disc of gel foam over the tube, which sits there and holds the flaps quite nicely.
Okay. Let's do an SPA ligation. How about we do that?
Yeah.
That's one of the
revision DCR. Someone's asking where it's all scarred to hell, and and the anatomy's bad. What are your landmarks? What are your safety steps?
Go where the other surgeon hasn't been, which is come anterior, come more superior. Go where they wouldn't have gone. Yeah, 100%. Okay, so let's go backbiter. Thanks. So I'll do it on this side. Now, when I do a DCR, SPA, I must say I don't normally do it just through the middle meatus. I always make a small antrostomy. So we'll very quickly do that. So give me a ball probe. Exactly the way that we did it. But I'll often do a half an antrostomy, Simon. So I'll find the natural ostium, stretch it, straight through cut, make my lazy L, and at least in this person I can get rid of all those accessory ostium. Not that I really think they cause much bleeding. And I just do, and when I'm doing a SPA, I'll go really close to the back edge because you want to get onto that bone straight away. And you come down, or go backbite, I think. And
this is, of course, even more important if you're doing a posterior nasal nerve section for autonomic rhinitis, because you need to get into that flap.
It's all the same. It's all the same anatomy. Vidian, posterior nasal neurectomy, and SPA. All the same anatomy. So shaver, thanks now. You can see I didn't try to pull it all out, but I could have. I'm just going to gobble it up here. And then I'll use this, then I'll do a suction, then I'll do a coddle. Got it in Raywin mode still. Excellent. So in a real life case, you just, by doing an inferior uncinectomy, connecting the natural os and making a posterior opening, you just get very good access here. Now, doing an SPA is so straightforward. People forget what the land. So when you make your opening here, is you just see the eustachian tube back here, go all the way back to the eustachian tube, and then sweep up. There's your SPA. Trying to dig around here and look and see the crista, this thing, it's not reliable. Just go straight. Can
you just show those nerves inferiorly? There.
Well, yeah, about to show them.
Beautiful. Yeah.
So you just go straight down and then sweep up, and you'll see it. So there it is there. Now, Simon wants me to pocket the posterior nasal nerves, right?
So
these, yeah.
Yep.
So that's what you divide in a posterior nasal neurectomy.
All of them.
All of them. You have to go right down. Now, I'll actually show it because we do it as part of a turbinoplasty. And I learned that from Ray Sachs. I've done that for years. Ray used to always take those nerves as part of a posterior, as part of an antrostomy. But here, when I'm doing SPA, you can't just simply see that little thing and stick a pair of bipolars on it. That's not an SPA ligation. There's often multiple branches here. So give me the kerosene up.
I think the average is 2.6.
Yeah, there's 2 to 3, right? So the first thing I do is I'll often widen it here laterally. And if you've got to do a Vidian, this is very important as well, because you need to push the PPF out of the way. You don't have to have a huge exposure, but enough that you can sort of really see the limits of the foramen. Give me a Blakeslee now. You can see that little triangle bit of bone's about to come off, so I'll fracture it, knowing that it'll always fracture because the canal will start below it.
And you diathermy as well as clip?
I just diathermy for most patients. Give me a caudal dissector. So once we've got this going now, we'll now mobilize below and we'll mobilize above. Give me a ball probe. That'll be another little branch coming off the top there. You can see a branch coming out, Simon. Can you see that?
Yep.
There it is there.
So that's the branch, the superior turbinate or the middle turbinate branch?
Hard to say. It might be even the beginning of one of the high septal branches, actually.
Mm.
That's obviously the sphenoid. So then once I do that, I will try very hard to demonstrate it, that I'm all the way around. But you're only all the way around once you've got that. See, I'm not even there yet. Let me do it properly.
Yeah, there's that branch. That's the posterior septal branch, isn't it, going across?
There I am. See that? So I just had to pull that. See how that posterior branch goes? And the reality is, and for a lot of, there's our two, they're coming through separate foramens, as you suggested. You know, so for a lot of people, that posterior branch is the most important. Let's do Metzenbaum. So I now will bipolar it, and then I'll divide it. And then I'll sometimes I always divide it. I don't put clips on very much though, but I do divide it. Give me a curette. Now that's what you'll do, give me a coddle, to start a Vidian. If you want to do a Vidian now, right, you don't have to go into the sphenoid, although there's some nice papers describing using the sphenoid and then doing the floor.
Coming down.
But you want to bipolar this. You can see that we'll pull the SPA or the PPF out of its other foramen here. So let's get rid of that. But this wall now, you want to remove. Give me a Blakeslee.
Posterior nasal nerve cryotherapy. It hasn't really taken off in Australia, and in fact, we had a discussion about this at a meeting in Singapore last year, where some of the American surgeons were there, and they said, you know, the initial enthusiasm about cryotherapy has waned off, largely because of the ice cream headache, and patients
and I think
don't
it's
like
maybe
it.
not as complete. You know, I think John Craig published that, you know, a lot of patients get symptoms back. I'll go sickle knife now. Now, this is one of the better PPFs on a cadaver here, Simon. There's the fatty lesion, the periosteum, coming down into the greater palatine. The branches of the SPA coming off, you can see that. You can see here how we've got now this tissue coming down through here will eventually become this up here, the descending root of V2.
Yep.
I've taken the medial wall off, and I really wanted to show this. This is not the Vidian.
That's the
This is
palatovaginal.
the palatovaginal, yes, exactly. Now, I still can't quite get it because this wedge is not too big. So give me a Blakeslee. Then we'll go back to the sickle knife. You've got to divide the palatovaginal. If you're not dividing the palatovaginal, you're not seeing the Vidian almost. You know,
and it was thought that a lot of reasons Vidian failed was that people were actually dividing the palatovaginal, and you've got to, it comes in a completely different direction.
45 degrees, isn't it? You can see it here, right? Now, there's some people who are starting to do things like a palatovaginal, a pharyngeal nerve ectomy for things like postnasal mucus and things. I must say, I've divided this nerve many, many times, and I have lots of patients who still say they have postnasal mucus, so I'm not sure I'm yet to accept that, but it's an interesting area.
I read those RCTs.
Yeah. And then here, like some other little nerve coming up through here, accessory palatovaginal maybe, Simon, and there is your Vidian trunk. It's a huge trumpet.
Looking straight at you.
Straight at you. Now there's the back of it. That's the Vidian nerve. There it is there. And I like to dissect as far as I can around it. Below.
Do you believe you can identify the lacrimal branch or not?
No. No. Well, I can't. But you know what? If someone shows me a day where they've defined it beautifully, then amazing. But what I do is I get all the way around almost a 360, and then at the very back, so you don't want to divide in the PPF, but back here, you then want to put your sickle knife. I just use the sickle knife and then come right through it, and then that way you'll get the final. And this whole PPF can often move forward when you've done that, especially if you've given a little bit of space by removing that bone. The PPF can come out of the way, and then you see this Vidian nerve. It's got a little Vidian artery in there as well, so you might have to
often bleeds.
And there's your palato-vaginal. Really great example of exactly what you said, Simon. It coming right at you. We're at 45 degrees. Now, someone said to me that when I do this surgery, Richard, it bleeds a lot. Well
that's for
what
the
you
artery.
do is you put a sucker in, and you park your sucker down here, like that. Give me a sickle. And then you use your instruments all above this sucker just sitting there. And that's the advantage of really making sure you've got that pocket. And it is worth, let's go Coddle, thanks, or Curate.
And the same's true for an SPA ligation.
Yeah, 100%. Just grab that sucker for me. And then you place this back, and then you get almost mucosa apposition.
Do you use bone wax in the Vidian?
I do, 100% if I'm doing a Vidian nerve. I'll stuff it with a small bit of bone wax to plug the canal.
So when I do posterior nasal nerve neurectomy, there was I think you mentioned his name earlier on, the New York surgeon, recommended putting a bit of biodesign in the flap to stop the nerves regrowing through the biodesign. There's not been a randomized controlled trial done yet, but it did sound like a logical argument. Someone's asked about the posterior pharyngeal nerve for autonomic rhinitis. I don't think it's got a role. I think, as Richard said, people are talking about...
Isn't that just the palato-vaginal? That's the pharyngeal nerve, isn't
Yes.
it? Yeah. I mean, maybe I don't understand that well perfectly.
There is another branch which comes off the pterygopalatine ganglion, which then joins up, I think, with the palato-vaginal, and they call it the posterior pharyngeal nerve.
I mean, correct me if I'm wrong, but that's it, right? That PPF is completely detached. The only thing's happening here is it's going down into the greater palatine and up into the infraorbital fissure to join the V2.
Yep.
There is nothing more. I mean, that is the pharynx is being completely separated now, you know.
So even though I won't do a Vidian, I'll expose up to the Vidian doing a posterior nasal nerve neurectomy to get those branches that Alki Soltis' group, identified posterior to the sphenopalatine artery.
And there's my little tear in that thing. So are we going to show a turbinoplasty?
We can do a turbinoplasty, and then we talk possibly just at least outline an anterior ethmoidal flap, artery flap. Someone's talked about anterior ethmoidal neurectomy. Now I've never.
John Craig is talking about this, about the idea that we do see some people fail Vidian neurectomies where they lose their lacrimation, but they still get an hypertropium responsive watery nose. It's not a very big group of people, but I do think it probably exists. I've certainly seen Vidian neurectomies be great, but not perfect. So there must be other parasympathetics that come into the nose. So, and there's my little tear.
And how do you find the anterior ethmoidal nerve?
I think this is all debated at the moment. I mean, right now I just shave the swell body off. That's my anterior neurectomy. So shave the swell body off, bipolar to the top edge, and that's it. Put a silicone sheet on, just like I would do if I'm doing a swell bodyectomy. Now, I've intentionally plumped up this turbinate just to make it realistic.
So, epistaxis in people with coagulopathies, would you still do an SPA?
It's not common, I don't think. So I think most of the time in coagulopathies, it's the coagulopathy that's there. And when I take someone to surgery, I don't do an SPA always. Like if I can see the bleeding spot, I'll just do a bipolar.
Yep.
I think that's really important. Can we put the tricut on? Now, when I'm doing a turbinate reduction, and the other thing I would say in that when you take people for epistaxis management, often their septum's really beat up and everything. Covering it with silicone sheets really helps the healing process, especially in that coagulopathy group, I think.
So especially in patients with HHT as well.
Oh yeah, for sure, 100%. Works well in HHT. So look, everyone's got their own theories about what they work well for turbinoplasty, but I guess in Australia, on the back of Ray Sachs and others, and we certainly have bad turbinate hypertrophy. We do a medial flap turbinate reduction. It works very well. There's a 15-year follow-up study just coming through to show that it really does give better long-term outcomes than just simple diathermy or intraturbinate debridement. Now, here we are now. We're going to remove the soft tissue tail until we see the attachment of the turbinate to lateral wall. So the soft tissue tail can be very big in some patients. Not so big in this person. I don't think they've really got much in the way of...
Whereas most of the ones we see, big mulberries.
Yeah. But I remove it all until I see the attachment to the bone. Then I come anteriorly here. I'll come up and I want to make a little window directly vertical up into the inferior meatus. And you can see now, we can see the bone there, so we can actually see. I didn't have to do too much here for this. Then here, we know the nasolacrimal's just there. There's that little slit for the nasolacrimal. It's in the lateral wall, the nasolacrimal. So I just want to score and mark off the apex here of the inferior meatus. I don't want the mucosa to strip across to the other side. So I just mark it off. I don't try to remove everything. And now I have to judge how much of a medial flap I'm going to take. Now, you don't actually need much here. The goal of this is to make a turbinate that sits in a more lateral position. It's not about taking the turbinate off or, you know, in my mind, even making a totally smaller turbinate. You just want a turbinate that is not as medially positioned. And so you have to work out what do you need to expose. And at the back here, very little. So I just want to see the cut edge of the bone. So we might stop there, actually. Give me a straight through cut, the little one. So I like now, I know some people will stay there and do a lot of shaving to expose the bone. I don't. I stop now and just divide the free edge here. Now, the reason I'm dividing the free edge is that it releases the periosteum around the bone so that when in a moment we're going to use a coddle, you'll see here that I'll be able to separate the medial flap really easily. So you got that coddle? Thanks.
Do you ever break it superiorly and then come down from the top?
I don't normally. I make sure it's released here.
Yep.
And I don't find the plane on the turbinate bone. I find the plane here on the piriform where it's very solid. So you can see us coming in here. You want to get very solid bone. See that solid bone? And you're really sweeping up at this angle. It's sort of like 11 o'clock here. Then from that plane, I want to come across. Sometimes the bone's thin. And then straight down through my released free edge. Then once I've got a bit of an opening, I'll put my camera in to hold the flap up, and then I'll sweep down. Now when the turbinate artery doesn't cross through the bone, you can raise this amazing flap and put your camera in a real-life patient. But at some point, you'll come across the bone, the artery transversing the bone. Now, if the bone's getting in your way, don't work around it. Just push the bone out of the way. Because the bone's going, what's important here is to preserve you want to preserve the flap, right? So that's the most important thing. Let's have straight iris, thanks.
And I think people have said, look, if they don't have the microdebrider, you can actually use the through-biting blade sleeves to take off that inferior bit and then find your plane.
Oh yeah, 100%. You don't
without
have
the microdebrider.
do you? You can totally just do it with cold steel. Yeah, I completely get. Here's the vessel. That's the vessel coming through that area. So at some point here, I sometimes have to release this again. I'll go straight back to the coddle. So I'll put a blade above and below, release that. Let's go back to that. Now, this is where it's going to differ from what a lot of people have done, in my opinion. You wait here. So this vessel that we got here, that has to be, in my opinion, it has to be medial to me. It cannot be. See how I'm forcing it to be medial? It cannot be on my lateral side. So, and I'll show you here in a moment. Give me a straight iris. All the blood supply comes down the lateral wall of the nose into the medial flap. So all of your little vessels have to be on that side. And now I want to curette, thanks.
You don't diathermy them?
Not at this stage. So now I'm going to release this. Now what you want is you want to raise the back ends to expose the artery and the little nerves. So here, you've got a good view. There you go.
There you go.
So that's antrum there. So you want to be all the way back. This is vertical palatine cum medial pterygoid plate. So you want to go back here like this.
And this is why you have to do a turbinate at the same time as doing your posterior nasal nerve.
Yes.
Otherwise, you're going to miss some of these.
Yeah, and I actually go and divide all those little nerves. And then in most turbinates, I can actually even see the SPA coming out. There's those little nerves again. There's a crista. It'll be just above here.
So these are those postganglionic parasympathetic nerves coming from the
there
ganglion.
you go. I was actually below it. There you go.
There it is.
There's SPA. SPA there. Look what you can raise. Give me a Metzen bum. And I usually can see it stripping a little bit here, but I'll often just release that because you want it to fold up. Give me a curette. And then once you get this mucosa raised, you just want to come forward, 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 forward. Give me a curved iris. Mets. And you want to take off this bone now all the way up. And you want to include what we call Linda's ledge. We have a nice student who did a great project where she showed that actually, you know, the people who need turbinate surgery are those who often have big bones and strong wet ledges. So the ledge is this bit of bone that's sticking out. And I see a lot of turbinate surgery where people just take the vertical shelf, Simon. Give me a Blakesley. And so what they're doing is they're just taking the vertical bit that comes down. But the vertical bit doesn't help you push the turbinate into a more lateral position.
It's the horizontal bit.
It's the horizontal, exactly. So getting this off here, whether you scrape it, bite it, whatever you need to do, and you can see we've preserved the mucosa. I'm even going to crunch this ledge down. And you know, sometimes the whole maxillary wall, especially in some kids, is pushing in. You know, I'll fracture it across. And then back here, I'll get you can see how when you've raised the flap really well, there's our two arteries. I could put a bipolar forceps and burn just this. I don't burn the whole turbinate, just that. And then coddle. And then at the very end of it, having bipolared the artery, removed Linda's ledge, I can fold this turbinate back like this, and I'll even undermine the head if I have to. See, I still think maybe a little bit more
So
there.
at the front, when you undermined the head, there was that little ridge that you took when you did the pre-lacrimal, which occasionally, with a little Blake's, you can just nibble that off.
Exactly. Give me the Blake's again. This is what you're talking about. I was sort of doing it half before, right?
Yep. You just take that
like
off.
That. You sort of, you can see it. This is Daniel Simeon's bit of bone that he likes to remove. And
I think because that's the nasal valve, isn't it? You know, you're maximising your turbinate lateralisation at the nasal valve region.
Yeah, that's exactly right. You're putting the turbinate into its most lateral position. And I think Daniel's idea of opening this little area up here is a good one as well. So there it is there. If I had to undermine it, say it's a bit chunky, and often is in allergic disease, I'll then put the shaver underneath, so you can see I re-raised it a bit more. And you can often suck a little bit of the hair, just like you might do in an intraturbinate technique, right?
Yep.
And then you lay that back down. You want it to be a little bit of concavity at the end. And look at that. It just looks like a nice turbinate, but we've really doubled the distance between the old turbinate and the septum. And actually, it's really preserving of the mucosa. Once again, got nothing to do with empty nose. Empty nose is a condition of patient selection, but it's about making sure that there's no raw areas for it to crust. You know, you want it to heal quickly. It's all in airflow. We're gonna shift something like 15 to 20,000 liters of air through our nose. We want everything covered. It'll heal nicely. It gets very good vascular control because you've bipolared the artery. You've got your posterior nasal nerve neurectomy almost as part of your turbinate reduction. And then the other one too, I guess here, it's a reasonably accurate volume reduction, Simon. You know, you've really decided you don't have to wait for heat injury and stuff to shrink your turbinate down like you do in some other techniques.
Yeah, and you bipolar that mulberry end at the back as well.
Oh, yes. That's a really good point, Simon, yeah. So where Simon brings up a good point. See how I did this area here? Although we've done the blood vessel, I often do exactly what Simon says. I'll just give that a bipolar.
Yep.
Because sometimes I think there might be a vessel that hooks back and its takeoff was slightly more proximal to where you.
Do you use Surgicel, Nasopore? What do you use to hold that flap?
I put Doyle splints in. I use a bit of pure region. I keep it really moist, and then I take the Doyles out at a week or so.
Now, with bipolar, the one you've got here is not the disposable one, is it? I mean,
this is the one I use in real life.
Well, so we're just going to show someone else what we do.
Oh, yes.
So I use a disposable bipolar, and I actually bend the tips so they actually sit apart. Because as you go in the nose, it tends to squish the tips together. Whereas, you know, and Larry Kalish has developed a fantastic technique where you can hold a sucker between the tips of the bipolar and essentially, hold them all in one hand, which is a technique I'm not dexterous enough to be able to do.
But the other thing I teach is that if they're starting to come together, you force your camera. See, my camera
between it.
is being pushed in between. So therefore, and then when I want them to close, I drag my camera out. You can see I slipped out. They come together. Force it in, opens it up. So that's the other sort of strategy.
You've got a 4mm dilator you can shove down. Now, if you've got a really bloody FESS cavity, do you do bilateral SPAs? Do you try and avoid packing?
No, I try not to do that.
You're going to get more crusting doing that?
Yeah, I think normally there's only a handful of big vessels you need to treat. It's the septal branch, the antrostomy branch, the middle turbinate artery, the inferior turbinate artery. They're all together coming off the SPA. And if you did have bleeding where you couldn't work out which one of those four was bleeding, to spot bipolar, I would do an SPA. And then I think anteriorly, everyone knows you should go looking for Aldo's S point.
Mm-hmm.
The idea of this just in front of the head of the middle turbinate, there's the anterior ethmoid artery comes down, and you can find a little telangiectasia there. And then maybe just something anteriorly, like a superior labial branch from the facial coming in here is occasionally. But those three places, here, and here, is the only place you can really get bad bleeding. And so if I've got those areas under control, it's just general ooze, then I just use things like silicone, thrombostatics, packing, Simon.
Yeah, just put a bit of cocaine, adrenaline in, sit for a few minutes.
Yeah, exactly.
And then use your bipolar very judiciously and very
Let's go
very locally.
Now maybe we can just very quickly show where the V2 is, and then maybe the final thing we'll do is show an anterior ethmoidal artery flap. We'll have to go back to the other side. So look, I'll sweep that away to show a bit of the back wall, because a lot of people ask me, they say, where is the IMAX? So the IMAX is very, very different here so we use this through a medial maxillectomy, so it's not the greatest of access. Let's go to the drill things. And what we're going to do is we're going to take a bit of this wall off, and I'll show you where the V2 and the IMA are in the infratemporal fossa.
So when you're doing your inferior turbinate, someone's asked, those little fragments of bone, do they delay healing?
Oh yeah, I take them all out. Yeah, if you can, take everything out so there's no little fragments exposed at the end of the case. Yeah, forgive me if I haven't totally tied them up on the cadaver, yeah. But I think that's a good call. It's good to get rid of them all. You'll find bone fragments at 3 months post-surgery if you haven't taken them out. Whenever you look in the nose at 3 months and you see a little crust somewhere, always take the crust off, because guaranteed to find a little bone fragment underneath.
Anesthetic technique someone's asked about? I mean, the
to
controversies of TIVA are sort of still out there, but it's the REMI that works, isn't it?
Well, I think there's no one answer, right? So when people ask me that, I say, look, you should be aware of all the maneuvers that give you good hemostasis. So the first one is you've got to have a sort of a bradycardic feel. Someone who's like in the 60s, a heart rate, and just normotensive or slightly hypotensive. This will give you a half a Bozert score improvement over someone who's just using either inhalation anesthetic or aren't keeping their heart rate low. If you give systemic tranexamic acid, this is associated with a half a Bozert score improvement. If you use topical non-selective alpha agonists like adrenaline rather than cophenolcaine, this gives you a half a Bozert score of benefit. And then reverse Trendelenburg. This gives you a half a Bozert score. Now, I'm quoting systematic reviews, not just one-off trials for that. So if you add all those up and you combine it with don't strip, that's a 2.5, 3 Bozert score difference. That's the difference between a field looking great and one looking terrible, don't you think, Simon? So that,
I mean, we have now routinely switched to tranexamic acid. There's no contraindications, really, even in patients who are, in theory, high risk. We still use it.
Yeah, exactly.
And clonidine, your anaesthetist should know all the techniques to drop that blood pressure and drop the pulse.
I'd rather than tell them which technique I do, I say to them, listen, I don't mind a bit of hypotension, but it can't be at the expense of bradycardia.
Yeah, exactly.
They've got to give us bradycardia. That's the most important thing of all.
And it's interesting. So on your iPhone, there is actually a angle meter. If you go to the measuring section, so you can actually measure the angle of the reverse Trendelenburg, and the anaesthetist will say, "Oh no, we don't want to risk a stroke," or and you can show them that in fact the patient's only at 5 degrees, and you can get another 5 degrees of elevation quite safely.
No, anaesthetists freak out when you've got them at 10 degrees. They think you're at 30. You know, like 20 degrees would be really standard for us. You know, yeah, like we wouldn't have no one would ever be slightly elevated. They're really quite a reverse Trendelenburg position. So here we go here. Now you can see I drilled down the bottom here, and while that's not necessary to find the infraorbital nerve, it is for the IMAX, and I'll show you here. Now I'm desperately trying to, in a cadaver, keep the periosteum intact. I'll do my very best. You can see occasionally a bit of fat's poking through. I'll try not to do it. And if you're going to start doing things in the infratemporal fossa, my only suggestion is really make your opening big. Don't make little bony openings and try to do something through it. You'll end up just getting little bleeding on the edges, and then they can't control it. You can't see stuff. And so I guess
somebody asked if you're around the SPA is bleeding. Presumably the questioner means if it's retracted, you can then use your keratins to nibble away back towards the maxillary artery and diathermy it there.
Yeah, 100%. If you'd have two choices. You could either pack it off there and then come and do what I'm doing. And if it's not too bad and you just need to chase it more proximally, then you could just continue across. The problem with continuing across is that there is this very thick bit of bone here.
Yep.
And, you have to use the drill on that really if you're going to get it. So, and that's because this bit of bone here is where this is the pterygoid root. So we've got medial pterygoid root coming this way and lateral pterygoid root coming this way. So it's very thick here. So it's not like something you can just sort of magically, sort of just nibble away with a keratin. I'm going to take this out here in a second.
I was involved in a post-trauma case with the multiple facial injuries and epistaxis, and going in there, and everything. Tried to find the SPA. It was just a complete joke, and really, the blood was so severe. We ended up just taking the patient to the angio lab and just embolized the maxillary artery. It was far easier.
Yeah, I think embolization is always a role. I think though, if it's a surgical case, I think trauma is a great one for angio. But it's like if you have someone who's had to be packed off after an operation, stabilized, maybe flown in or transferred in, you should take that patient back to theatre. Because I think embolization does carry risks, and I think if the surgeons cause the bleeding and it's not the carotid, then I think you can manage it mostly through operative. But like you said, I think if you've got potential carotid, unknown patient, unstable, many other traumas, embolization, great way of doing it.
So do you preserve the posterior maxillary mucosa and use it as a flap?
I sometimes try to, a little bit. I don't think it's always necessary.
No risk of mucocele?
Yeah, I think you're more risk trying to preserve it, and then you get issues. Give me a sickle knife now. So when you get this open here, first of all, you can see the V2 up here, right? Now the V2, look how it disappears down low here. Can you see that? This is what I wanted to show everyone here, just very briefly. See how it drops a little bit low there in the cavity? All JNH surgeons, give me the Blakesley. And I'm going to give you a bit of fat here. You bipolar the fat in real life, but in a cadaver, you just sort of pluck it off.
It's actually really good to dissect through here bloodlessly is the coblator.
Yes, coblator is awesome. That's a great call. But I wanted to show how the V2 often sits quite low. So look where it is, guys. See here? I think some people think it's up here, and it's just not. And this is why occasionally it gets injured by some people. Just be mindful that it does sit off this area and can hang down low like that before it then suddenly disappears into the floor. Now, let's go now and do the IMAX. So give me a sickle knife.
People are asking about IMA ligation versus SPA. I think for tumours where you need to get it more laterally, or post-trauma where the bone of the lateral nasal wall has been fractured, that's really, would you say, Rich, just tumours and trauma?
Yeah, correct. Yeah, 100%. So here we go here. I really think I use Metzenbaum a lot here. So when you see the pulsating area, you can see the vessel, unfortunately, too easily here. But you'll see it pulsating. Put your forceps in and stretch it like that. I can't tell you how useful that is. It's not tight here. You're not going to tear the artery. Put it here and stretch it. And dissect it like you would in a neck, Simon.
Yep.
You know, really dissect it. Now what you're looking at here is a T-junction. I think this is a really important that I didn't even when I started as a consultant, I didn't quite get this idea that what I'm looking at here, and you can see why I removed this bone down here, right? Because of like, you know, even here, give me the kerosene up. We're not quite going to see it here. So this is it's coming towards us and then splitting off laterally and medially. Give me a Blakesy. And so this is, it's not coming from over there and coming in. The actual artery is coming at us here.
If you're doing a JNA, will you pre-embolize it?
Yeah, I usually do on very big ones. But, you know, I acknowledge that our colleagues, we got some great colleagues in India who do big lesions without embolizing. You know, and then just bipolar, or as Simon said, coblate. So you see this now. See, I think that's probably as good as demonstration. See it there? It's coming. I actually think it may be coming through here. That's its point. That's where it's coming at us. See that? So that's my biggest learning point here, is that that's the origin of the IMAX here. Can you see that? So it's coming out of the pterygoid muscles, comes forward, and then it does this like this T here. So if you clip here and think you've got it, or clip here and think you got it, you haven't. It's here. You know, this is it here. Well, actually, maybe if you clip just on this side, we'd have it. But it's this thing here. And then it'll create these branches that'll come up and around and over here and down here. But this actually will be where the arteries come up. And I wonder if we can just keep going and just very quickly, let's see if we can chase it back to the muscle without me. I'd bipolar in real life if I was trying to get rid of this. And I put a clip on the IMAX, so we were talking about
multiple clips.
yeah, because it ruins the day once you make it bleed. But you can see where it's coming from. It's coming from way out here. Depends how much fat's going to be in this. Oh, here we go. Here's some muscle coming up. I was hoping to show you the muscle belly and it coming through. Yeah, we do. We need a... That's the beginning of the muscle. So there's muscle there. And there's IMAX.
You just fix the patient's bruxism.
It's amazing. You get away with nibbling a bit of maxillary. There you can see there's the vessel going back here, back, and then into this muscle. There's the muscle there. And there's the IMAX coming into it. So ball probe. So getting the IMAX means really making sure, rather than putting 1,000 clips on, you're better off to sort of dissect and be very convinced that you've got the proximal branch here. Now, of course, if you can't see it, Simon, I'll clip, divide, move it out of the way, then chase it and things like that. That's a good example there. And we were going to do one more. Anterior small artery, and then I think we call it maybe an early finish.
Call it a day. Now, the other thing with your clips is that it's important that you make sure you've got the clips that have the serrations at the end. If you've got the smooth clips, they're prone to fall off. And so for those of you that the start of your career or maybe going to a new hospital, make sure that your sphenopalatine artery and maxillary artery clips are the ones with the teeth at the end, because the ones without fall off.
Okay. Now, let's have a look. What can we do here? We'll do this side, right? Now this person does have a bit of a tear, right? So, to me, that doesn't make the best side for an anterior femoral artery flap. If I was going to do it, I'd do it probably on this side.
Side, yep. That'd be where your septal perforation would be anyway, wouldn't it? Where the tear is.
Should I make a little more here rather than the one on the other side?
Yep.
So look. I'm gonna make it on this side, right? Say this is my septal perforation, right? Because that's likely to be where a perforation would be, just there. Don't you agree?
Yep.
It's in the finger zone, Simon.
Yep.
You know, so there we are there. Forget that I've made an incision here.
Or
right?
the cocaine zone.
Ignore that for the sake of the education purpose. So people ask me, like, this is the best side to use because there's no ridge or anything else. But if we had this side where there was a funny ridge, I'd pick the side without the ridge because it's just, you want the blood supply to be good. Now, the first thing I do is I give me a big wash. I'll get rid of the stuff inside the nose. Give me a freer thing. You have to appreciate where the vessels come out. This is why Islam's course is great. So here's that area that you would need to push across. Remember I said to you, get rid of those adhesions? Yep. Push the lateral lamella. I push it in a lot of people. Get it out of the way. Okay, so give me the sickle knife. Now, it is hard to do without the needle point, but the back cut of this is in line with our superior meatus. So there's the superior meatus there. You can see that? So this is where you're making your back vertical cut. High up like this. The anterior femoral artery enters over here. So you've got to be at the level of the superior meatus. It's really a long way back.
If you come too far forward with this incision, your flap will die.
Yeah, correct. Yeah, and there probably is part of this flap that also is it's random pattern, right? So so you want the top pedicle to be as broad as possible. So here we are now. So we come down here. You're not trying to preserve septal branches and things here. This is, you cut through all those, and you sometimes will see them. Obviously, with a diathermy, it's very slick and easy.
Do you ever use double flaps, or just do the one side now?
I sometimes use, I've been attempting Isam's turn-in flap technique. What does he call it? Everted edges technique.
Is that like Aldo's flip-flop flap?
No, it's just taking the edges of the mucosa and turning it in. Yeah, if you read anything from Islam Alabid, he's very big into everted edges. You can read up about what that's all about. If you're interested, those listening.
So it is interesting because the everted edges techniques logically shouldn't work because...
Oh, it's just a bit of random pattern.
Yeah.
Yeah, exactly. It seems to do. The only thing I don't like about the everted edges is when your edge is really squamous and crusty, you know, which I like to get rid of it. Okay, because it's not about just closing the hole. I've got to give the patient a septum that doesn't crust. So there's my very awkward sickle knife dissection, and it's super slick with the needle point. But the same principles as before. You've got to feel then the hard palate. Come right out here, and like very commonly, you are taking a lot of this right up into the inferior meatus. So much so that we'll even lift this up. And then as we come forward, you want to then duck down below the nasolacrimal. And this is obviously for an anterior femoral artery flap. Give me a sucker. We've got mucus here, right?
And you bring it anterior to your perforation, if you can.
No, or just to the back edge. Just to the back edge is fine for me. And a couple of practical things, like sometimes, like you know, if it's, you know, I'll avoid the incisive if it's at the back of the perforation already. Yeah, I just come to the back edge here because it creates a more uniform flap. But I agree with the concept of making it as anterior as possible. And I'll show you a couple little tricks. So this is always a bit tricky down here. We'll make sure, and like I said, with the needle point, super slick. Now with this top release then, often you can get away with just a small triangle or release. You don't have to make a huge one. Give me a Metzenbaum, because we've already dissected this, so I'm not gonna dissect it hugely. Okay, now give me a knife. So often at the back edge of the perforation you can start the dissection, but like all times, I always say, do what's easy on the floor first. Feeling the bone, it's all about the bone, not about the mucosa that we're dissecting. If your surgeon had cut it properly, give me a Metzenbaum, yep. Okay, give me a Cottle then back. So I'll do all this now, get this as best as I can because I don't want to come back here, right? As I start doing my dissection, I'll make it bleed. So I get all this back edge off. And once you do it with the needle point, you don't have, you can see how my sickle hasn't come through it properly. It's got lots of little tags, but it's got to be very mobile. Now, coming here at the front, you've got to get through the incisive frame and see this here? So when you do it, don't pull it too much. Try to really cut it, because I think if you pull it, that's when you're likely to get a bit of teeth numbness. But too much traction on this nerve is probably going to give you teeth numbness in some people. So there it is there. Come forward here, all the way, there we are at the back, here we are up here. You can see I've already come through, but if I hadn't come through, I'd divide it again. There we are there, and this has all been released. And give me a tooth forceps. And you can see by this very high release here, see it's not quite released there. See how it's holding on, Simon? Yep. So give me a Metzenbaum.
That's what you need for the rotation.
Yeah, you must make sure this is released, and you've really got to have, a very convincing dissection vertically up at the level of the superior meatus. Now, I think even though you might be getting into the bottom of the smell cleft here, because you're making just a vertical incision, I think your impact on the smell is really minimal. Give me a sickle. I don't have an instrument here. But the fact that I've still got hard bone here, right? So I know we're still pretty low, actually. You can see where I am, right? I'm not even at the, most FESS surgeons take more in superior turbinoplasty than that, right? But getting this vertical release is critical. Because exactly as you said, it's what gives the rotation, Simon. Okay, give me a tooth. Now, when it's done properly, here we go, it should be able to come out the front of the nose. Uh-oh.
Still tethered somewhere.
Exactly. Oh, here it is. Here it is.
When people say they can't get a long enough flap, you do not need anything longer than that.
Yep. 100%. You should be able to always produce it sitting loosely like that, sitting, and I probably could even finesse it even further out the nose than that. And therefore, that's your flap, and that's how you would cover all of this. And then when you do it, you don't suture this, Simon, to the front edge of the perforation. You must create a bed in front of the perforation. And this is where ISAM folds in that edge.
Yep.
And therefore, that edge then comes in front of the perforation. So the edge of the flap doesn't go onto the edge of the perforation. It must come anterior to it. Blakesley?
So he'll use that anterior bit to go onto the opposite side of the nose.
Yeah, and he'll fold that in. And like you said, I do think it does better than a free flap. So there's obviously like a little bit of, blood supply phenomenon still happening, random pattern or something. And there's the flap. And look at that. Look how we got that all the way forward into the nose.
Yep.
And then, of course, you create posteriorly an area that has to heal by secondary intention. folded or flap. You've got to cover it with silicone sheets for a long, long time. You can choose what you do as an interlay. If there's a big dog ear, you can dissect it. If it's not too bad, like this person, I just put the silicone over it. It hides itself. And
don't put too many sutures high up, otherwise you can actually devascularize your flap.
Yeah, I just put about 3 here, maybe 1 through and through at this level just to hold it up. And then I use an interlay of collagen matrix. But some people don't do interlays. If you're doing everted edges, I don't think that goes. You could use fascia, temporal fascia. But I think, I don't know if Mandy or the Hong Kong team is still there. Simon, what do you think? We can answer a couple of questions, but I think really...
that's pretty good. I mean, someone's asked about monopolar cutting cautery. Yes, but a really fine point.
Yes.
Don't use a broad point, otherwise you'll just create such a wide burn trough. So a really fine point needle diathermy is what you need. Last questions. Tragal cartilage for septal perforations. I mean, whatever works, really.
Well, I think you can use any interlay you like, but if your only technique is just stuffing something in and pulling the edges close, that's not the same as vascularized flaps. Just putting something that lasts longer and hoping the mucosa grows across is still going to give you a degree of uncertainty of your outcome.
Yep. Cool. All right, so listen, just before we close up today, I'd just like to thank the AV team today. I think it's been excellent, and I hope for those of you online, you've enjoyed their work. They're extremely good at their job, so thanks, guys. And there's actually a great support team of juniors and other ENT surgeons, as well as...
thanks Ling,
who's done our fantastic...
scrub, scout, and... prep and pack-up nurse. Thank you.
Great. And finally, great thanks to Richard.
Thanks, Simon.
For those of you that have never done this before, to keep going like that for over 3 hours, it drains you. So I think Richard is well in need of a beer or a nice glass of red tonight. All that leads me to do is just say thank you all for dialing in, and if you've got any further questions or anything else, please feel free to email APOST and Mandy can flick questions onto us. But it's really been fantastic. Each time I think these dissections get better, and hopefully we look forward to seeing you again in the future at an APOST event. So have a great weekend, and for all the mums out there, happy Mother's Day for tomorrow.
Fantastic. Thank you very much.